Well, good morning, everyone. I'm here in place of Mandy Andrews, as she's double booked. So I'm delighted to be able to be here this morning and bright and early. So it gives me great pleasure to introduce the speakers today. And just bear with me till I get into my... Okay. So integrated care, intermediate care. Our first speaker today is Anariek Stoop. And I won't say anything else about Anariek, and the speakers will introduce themselves. But I'll just be the timekeeper. And if you see me standing up, your 15 minutes are just nearly there. So welcome, Anariek. Okay. And we'll keep questions to the end, if that's okay.
Can I just do this? Yeah, perfect. Okay. Yeah, I think it's working. Well, good morning, everybody, on this very early morning. I'm happy that we have some audience this morning, so thank you for coming. My name is Anariek. I'm a PhD student at the National Institute for Public Health and the Environment and the University Medical Center in Amsterdam in the Netherlands. Today I would like to tell you something about the outcomes of the SUSTAIN project. The SUSTAIN project is a project about a cross-European research project about improving integrated care for older people living in Europe. And today I would like to present the overall outcomes, and everything that I am explaining this morning can also be found in the overarching policy report, which can be found on the SUSTAIN website. Well, first of all, I would like to explain a little bit about what the SUSTAIN project actually is. So, in the SUSTAIN project, we aim to improve, establish integrated care initiatives for older people living in Europe, and we also would like to monitor and evaluate these improvement processes. And on the other hand, we would also like to contribute to the adoption and application of these improvements to other health systems and regions in Europe and abroad. Well, in the SUSTAIN project, we focus on 5 key domains, which means that we actually want to improve 5 domains of health and social care delivery. So we want to make care and support more person-centered, prevention-oriented, safe, efficient, and coordinated. Well, in all these initiatives focus on older people with multiple health and social care needs. And the initiatives that participate in the SUSTAIN project are located in 7 different countries, which are Norway, Estonia, the United Kingdom, the Netherlands, Germany, Austria, and Spain. And all these different initiatives are very different from each other, so they have a different target group. Some focus on very frail older people or people with dementia, and other are more focused on older people with some needs but not too frail. And we have different initiatives. They provide different types of care and support. So some are delivering dementia care, some are providing proactive primary care, some are focusing on transitional care, which means transfers between hospitals and home. And we also involved rehabilitative care and home care services. And in all these initiatives, they want to improve the current ways of working. And they all, in all these initiatives, they implemented improvement processes. And I will explain what we've done throughout the SUSTAIN project. So we had a participatory approach in which we collaborate with local stakeholders from these 13 initiatives. And to have to have this participatory approach, we first started to have working relationships with local stakeholders from the initiatives. So we started to getting to know each other, and we have interviews and sessions with them in which we want to know about our integrated care initiatives. So what are the characteristics of the initiatives, but also what are the challenges and barriers that they perceive towards integrated care. Then we have workshops in which we together with the local stakeholders identified potential improvement areas, and we designed actual improvement projects in which they state what they would like to improve in what time frame, etc. Then these improvement projects were rolled out by the local stakeholders from the initiatives, and the improvement processes were monitored and assessed, and we provided feedback to the local initiatives about how they were doing, about the progress and the outcomes already during the implementation of the improvement projects, to give them feedback and for them to be able to refine their improvement projects. And to analyze the improvement project, we adopted a multiple embedded case study design, which means that all individual initiatives were perceived as an individual case study. And to build a case study for each site, we have different ways of data collection. So we have interviews with users, interviews with managers and professionals, interviews with informal carers, but also focus groups. We did surveys, we had observatory data, so we have all different kinds of data that we collected, and all data for each site were analyzed. And as such, we were able to build an individual case, and that we're able to do a kind of site-specific analysis. And the outcomes of the site-specific analysis were compared and integrated to be able to make an overarching analysis in which we compared and integrated all lessons and experience from the different sites. And today I would like to focus on the outcomes of the overarching analysis, so in which all experience from all sites were compared. So first I would like to explain a little bit about the improvement projects. We saw that among the 13 initiatives, the things that they would like to improve were different from each other because local stakeholders decided themselves what they would like to improve. But we also saw commonalities between the improvement projects. So some sites were focusing on improving collaboration, communication, coordination between health and social care professionals and organizations involved. So getting to know each other and also understanding each other's roles and responsibilities. On the other hand, we have also projects that focused on improving the actual care delivering processes. So for example, making the care process more person-centered. Well, what kind of integrated care activities were part of the improvement projects? We saw that despite that the improvement projects had some similarities, we saw that every initiative had its own unique combination of actions and activities in the improvement projects, but we saw that the initiatives undertook activities in similar areas. So for example, in most of the sites, they conducted new ways of doing needs assessment and developing care plans, for example, by involving older people and their informal caregivers and discussing their needs and preferences. But we have also activities that were really site-specific. For example, in the Austrian site, there was staff training to professionals from the hospital about early detection of dementia of people admitted to the hospital, and that was only taking place in the site in Austria. So we made a difference between site-specific activities and more generic activities. And most of the activities were addressing person-centeredness, and less activities were focusing on safety and efficiency. But in the end, actually, most activities addressed several key domains at the same time. So for example, in one of the sites, they were changing the location of rehabilitative services from institutions to homes. And with that, they hoped that people feel more comfortable, and also the advice was based on their own situation, and they hoped that services were more person-centeredness, and simultaneously they also hoped that by avoiding unnecessary transfers between hospitals and home, they also make care more efficient. So they were addressing several challenges at the same time. So what seems to work then? Well, actually, we saw that the majority of the activities were able to improve person-centeredness, prevention, orientation, safety, efficiency, and coordination. So, for example, in one of the improvement projects in which they would like to make people more comfortable living at home and enable independent living, people really indicated that they feel more comfortable to live at home and they feel more safe to live at home. But on the other hand, we also saw some activities that did not work out as they hoped, as they intended, or activities did not work for particular groups of older people. So, for example, in one of the sites, they have activities about empowerment and involvement of frail older people, and it turned out that it was too much for this frail population, and they were not able to be involved as professionals and managers hoped that they were. And on the other hand, we also saw some discrepancy between the views of managers and professionals and between the views of users and carers. So professionals and managers were often more positive about the outcomes of the improvement project. So, for example, they found that involving other people in the care planning process, that was very positive and it improved person-centeredness. But we also have interviews with some users and informal carers in which they indicate, well, actually, I'm not involved at all, or they only talk with my informal caregiver and they don't talk with me. So there was still some discrepancy, and it was very interesting to see that professionals and managers do perceive improvement different than users and informal carers. We also saw that the evidence on improving person-centeredness was more available than improving safety and efficiency. And this was because there were more activities on improving person-centeredness and there were less activities on safety and efficiency. But on the other hand, we also saw that the managers and professionals from the sites indicated that the limited time frame of the SUSTAIN project, which was only 12 months of implementation of the improvement projects, that it was too short to be able to notice any differences. So, and why did some things work or did not work? Well, we saw that some of the explanations for succeeding or for not succeeding were related to the characteristic of the integrated care activity. As I explained, some activities are not suitable or not appropriate for the most frail population. But on the other hand, we also saw that some explanations were related to the context in which the activity was implemented, and we distinguished three different levels of the health and social care system, which were explanations for succeeding or for not succeeding. So we had the micro level, the meso level, and the macro level. And on the micro level, we saw that the motivation and the commitment of the professionals who were actually implementing the improvement projects, that was a very important reason for succeeding or for not succeeding. On the meso level, the presence or the not presence of leadership and ownership of some leaders was an important point for succeeding or for not succeeding, and also if there were available, if there were resources and time available for professionals to actually implement the improvement projects. And on the macro level, we saw that there were some national and regional policy and legislations which helped or hindered the implementation of improvement projects. So overall, we saw that there were the factors that explained success or not success of the improvement project were quite generic and were observed in most initiatives, but we also saw some factors that were site-specific. So for example, in one of the countries, we saw that the professionals did not have a very positive attitude towards older people, and for them it was very hard to involve older people in the care team and as being part of the care process. And we also saw some political, historical context. So in one country we saw that it was hard for older people to be involved because they were not used to raise their voice, or they were not used to give their opinion about things, and it makes it harder for them to also be involved in expressing their care needs and preferences in developing a care plan. Well, we also have, in the overarching policy report that we prepared, we also made some recommendations to improve integrated care. And we made some recommendations for policymakers, for service providers, and for the research community. And I would really like to encourage you to read the overarching policy report, to read all recommendations, but I will just mention one for each of them. So for the policymakers, we would like to encourage to have dedicated funding for integrated care. So from many sides, they indicated that funding levels were not sufficient, they were unstable and not sustainable, and there were also financial barriers to work together between the healthcare sector and the social care sector, or between the primary care and secondary care. And to have funding systems that are appropriate for integrated care, we might overcome such barriers. For service providers, we would like to recommend that the starting point of improving integrated care is first to identify what is important for older people themselves, what matters to them. And they are older people, and our informal carers are important actors in integrated care, not only in their own care process, but also in the larger processes of improving services. And to have interprofessional collaboration, it is important to first get to know each other, to know who the other professionals are, to know each other's roles and responsibilities, and really invest time in knowing who is also working with older people in your community or in the area that you're working in. And for the researchers, we would like to suggest to consider alternative study design. In the SUSTAIN project, we used the multiple embedded case study design to evaluate and monitor improvements in integrated care. And we all know that it is hard to evaluate integrated care. And we also know that traditional ways of doing research, like the RCTs, are not always feasible for evaluating integrated care. And alternatives like the realist evaluation and case study design may also be a good way of evaluating integrated care. Well, thanks for your attention. For more information, just contact me or visit the SUSTAIN website, in which all things about the SUSTAIN project can be found. Thanks.
Thank you very much, Anna-Riek. And we'll have questions at the end. Is that okay?
Yes, of course. Yeah, thanks.
And we'll now welcome Marie-Angelis from who's going to speak about frailty.
Good morning, everybody. My name is María Ángeles Caballero, and I am here on behalf of Advantage You in Action. I will speak about context of the problem, what is Advantage You in Action, a state-of-the-art report, survey member state, example of good practice, and conclusion. Demographic aging is one of the most serious challenges in Europe. Older people are at the greatest risk of becoming frail and developing disability. However, frailty is not an inevitable consequence of aging, and thus may be prevented and treated. Frailty has a clear impact on the cost of health service. Recent studies have determined its incremental cost ranges from 1,500 to 5,000 euros per person, depending upon the frailty status, preferred or frail. To do so, it is crucial to develop evidence-based support what makes frailty entering the top of the public health agenda in Europe. The concept for such situation motivated to create the First Joint Action on the prevention of frailty. It is co-funded by the European Commission, by Parliament, and many of the Member States through the third European Health Programme of the European Union 2014-2020. Advance, which brings together 33 partners from 22 member states for 3 years. Advantage Generation aims at building a common understanding on frailty to be used in member states by policymakers and other stakeholders, which should be the base of the common management both at individual and population level of older people who are frail or are at risk of developing frailty through the European Union. The implementation process has 3 phases. Phase 1 summarizes the current evidence of the different components of frailty and its management. In this phase was created the state-of-the-art report. In Phase 2, propose a common healthcare guideline or frameworks to approach frailty. In this phase was created the frailty prevention approach document. Phase 3, advice policy recommendation is collected in roadmaps. Across all phases, increased knowledge in the field of the frailty indicated what should be prioritized in the next year at European, national, and regional level. The work for delivering the Advantage Generation is structured in 8 work packages. Work Package 7 analyzes health and social care model for frailty management. In this presentation, I will focus on the results. The goal of the Work Package State-of-the-Art reports was to summarize and analyze the evidence obtained from 4 sources of information: peer-reviewed articles, GRI documents, good practices identified at European level, and European-funded projects. Each work package discussed their main findings and developed their one topic-specific state-of-the-art report. Each report was critically reviewed by 3 out of the 7 members of an expert panel and later discussed in a workshop with the expert panel, the coordination team, and the work package leaders and co-leaders. The updated and revised final version are available to the Advantage Generation website. The Advantage Generation State-of-the-Art report is the first step towards a common approach to tackle frailty at the European level. Advantage recommends about what components should health and care system adopt to manage frailty are holistic social care support and enablement, continuity and coordinated in primary care, comprehensive assessment in hospital, intermediate care and management of transition. Key components of model of care are a single entry point general in primary care, single frailty screening tools in all settings, comprehensive assessment in individual care plans included for caregivers, tailored intervention by interdisciplinary team, case management and coordination of care and support across providers, effective management of transition between teams and settings, set electronic information tools and technology-enabled care, and clear policies and procedures for service eligibility and process. In addition, we created surveys based on areas of information of state-of-the-art. This complements the state-of-the-art literature review and was designed to identify experience yet to be published. The information needed to portray the situation in a given member state was requested through a questionnaire addressed to policymakers and managers at national or regional level of each member state. 21 reports of each member state were analyzed. The consortium aims to analyze, discuss and use this information to build consensus for a common frailty prevention approach. Work Package 7 identifies and shares examples of good practice on model of person-centric care and support in different settings: primary health care, community care, social care, and hospital care, in order to prevent or delay progression of frailty and enable people to live well with frailty. We consider that good practice are modeled with all key points of state-of-the-art. Analyze the transferability for scaling of model of care with other aims. We identify this good practice in Finland, France, United Kingdom, Italy, Spain, and the Netherlands. To analyze the transferability to scaling up of this model of care, we consider political support, governance, enablement, organizational change, leadership, collaboration, forward education, patient empowerment, finance and incentive, easy things and monitoring. The 6 examples featured in this report share several common success factors: a strong political support, legislative frameworks, financial incentives, leadership and support to change the professional culture, screening and risk prediction tools to select frail-older people for intervention, and person-centered and holistic approach. Model of care should take into account the need for approaching older people not just in terms of their diseases, but also in terms of physical, cognitive, and psychosocial care and support to prevent functional decline, frailty, and disability. This model is possible. The case studies in this report can be used as a source of inspiration for policymakers, managers, professionals, and wider stakeholders. I want to invite you to follow us in the campaign of Fatal to Frailty in Twitter and in Facebook, and thank you for your attention.
Thank you so much. And our last presenters, are you going to do it together? Yeah, okay. So welcome, and I just need to get into my screen again. What's your guys' names? Christina and Tamara. So welcome, and
Good morning. Yes. Good morning. My name is Cristina Alexandru, and I am from the University of Edinburgh School of Informatics. I have been involved in the development of the Sirocco tool as part of the Sirocco project, and more recently the Sirocco Exchange project. And I would like to briefly introduce to you the main functionality of the tool, especially the one which supports knowledge transfer in integrated care. And after me, my colleague Tamara Alhambra Boras will also present the evaluation, the results of the evaluation of the tool. So, as I already mentioned, the Sirocco tool was developed as part of the Sirocco EU project. It is based on the maturity model developed by the B3 Action Group on Integrated Care of the European Innovation Partnership on Active and Healthy Aging. I have provided the link to the tool. It is a public and free tool, so please feel free to access it and register, and you can use all of its functionality. The main aims of the tool are those of facilitating the scaling up of integrated care by first of all defining maturity to adopt integrated care through its use of the B3 maturity model. Then assessing the maturity of healthcare systems as well as the maturity requirements of good practices. And finally, supporting twinning and coaching, both to transfer good practices into new healthcare systems or to facilitate the improvement of healthcare systems. I'm going to focus on the assessment of maturity of healthcare systems and twinning and coaching for facilitating the improvement of healthcare systems in this presentation. But before delving into that, I'm just going to briefly explain that we have 12 dimensions as part of the maturity model that the Sirocco tool is using. Each of these 12 dimensions has been obtained through interviewing specialists across Europe, and it was validated through a Delphi study. Each of the dimensions has 6 rankings, from 0 to 5, as well as an associated narrative explaining the objectives of the dimensions. Starting with the functionality for assessing the maturity of healthcare systems, which is the most used functionality of our tool, we recommend going through the following process. So first of all, local organizers identifying local experts to be involved in the assessment, then the experts individually performing the assessment by using the Sirocco tool, sharing their individual assessment with the organizers, and the organizer setting up a workshop to discuss and reach consensus amongst the different experts as to the maturity of their healthcare system. Let's take each of the steps in turn. So in the first step, you can imagine that people with very different levels of expertise and experience can be involved. So for example, we could have a team composed of a doctor, an IT specialist, a nurse, and an administrator. Each of them would need to individually perform an individual assessment of the tool by using the Sirocco tool. An individual assessment of their healthcare system by using the Sirocco tool. And for this purpose, they can use the maturity assessment page. On the left-hand side of the page, we can see a form containing the 12 dimensions of the maturity model. For each dimension, we have rankings from 0 to 5, and users can move between the dimensions either by clicking the arrows or the question links from the top. As soon as they record the ranking, it will automatically also be represented in the spider diagram on the right-hand side, or they could directly use the spider diagram to record their rankings there. So we have the dimensions as the labels from the axis of the spider diagram. As soon as they have provided a ranking for a dimension, they must also justify it in the text area underneath. And finally, of course, click Save. As soon as the specialist has filled in an individual assessment, they will next need to share it. But you could imagine that because of their different expertises and experience, each of the specialists may end up with a very different assessment of their own healthcare system. To share their assessment, they can use the Share Assessment page and provide the email addresses of all of the colleagues they would like to share the assessment with. And then, during what we call the consensus meeting, the team would all get together and discuss each of the dimensions. So they can see comparatively all of their individual assessments, both on the form as well as onto the spider diagram, by being represented in different colors. The legend helps because it shows what the different colors mean, and also by clicking on the labeled names with the different colors, one can open up the individual assessment in a different tab. So they can also look at the justification underneath each ranking given by each of the people, again by using the different colors. They would need to go through all of the dimensions one by one and discuss the ones where there wasn't consensus. So for example, if we have standardization and simplification, we see that people have disagreed on this, although two of them consider that there should be a ranking, the other two disagreed. So there would be a discussion and reading of the different justifications, and they may decide, for example, to go with the ranking proposed by the IT specialist. So they would record this onto that page, as they do for any assessment. And finally, going through all of the dimensions, they would end up with what we call the consensus assessment, represented as black to stand out comparatively to the other assessments. Okay, so this was the process for assessing the maturity of a healthcare system, but for good practices we go through a very similar process. The only difference being that this time we would need to look at the features of the good practice, the features of the healthcare system that the good practice needs in order for it to work. Going on to the next functionality, using the tool to facilitate knowledge transfer, twinning and coaching is the process we use for knowledge transfer. So we have two ways of doing twinning and coaching in the Sirocco tool. The first one is between two healthcare systems, where one system learns from another more progressive system in order to improve its maturity in a particular dimension of integrated care. And the second type of twinning and coaching is between a healthcare system and a good practice, with the healthcare system learning what it needs to create in its local context in order to enable the adoption of the good practice. So this is for scaling up the good practice to this new context. I'm just going to focus on the first of these types of twinning and coaching processes. So experts who have previously assessed the maturity of their healthcare system, as we have just seen in my previous description, can use the Sirocco tool, first of all, to identify one dimension to mark as a priority for the improvement of their maturity. Then to see other healthcare systems which scored higher on that priority dimension, and so they could learn from them. To invite those one candidate healthcare system for knowledge transfer. And finally, to have a discussion on the features that they would need to implement in order to improve that particular dimension, how feasible those changes are, and what adaptation would be needed in the local context. Let's take each of the steps in turn. To record the priority dimension for the improvement, the user would just need to go back into their consensus assessment that we've just seen. And here in this edit mode of the page, they can just go to any of the dimensions and tick the radio button underneath, which says mark the name of the dimension as your #1 priority. And this will automatically also label the dimension as a priority onto the spider diagram. Then, if they want to arrange for a twinning and coaching meeting regarding, for improving that priority dimension, the user can just go to the list of their healthcare system assessments, take the healthcare system that they are focusing on, and click on the twin button, which becomes active once they have a priority dimension. This will lead them to the page where they can see other healthcare systems that do better than them, that perform better than them on that one priority dimension. They can click on the link representing the name of each of those healthcare systems, which opens up a separate page with the comparison of their two assessments. Then, if they decide to go with one of those healthcare systems, they can return to the original tab and click Invite for Twinning and Coaching. And this will both show a confirmation on the page, as well as send an email address, both as a confirmation to the originator of this invitation, as well as to the organizer of the invited healthcare system, in order to invite him for a twinning and coaching meeting. As soon as this has been performed, the tool also records that there will be a future meeting within the Twinning and Coaching tab. So the user can access this tab either during that actual meeting or after it, and within the healthcare system to healthcare system column, they will find the association between the name of their healthcare system and that of the invited healthcare system, and open it up using the edit icon. This will take them again to the comparison of their two assessments, but additionally on this page, they can also, through discussion, decide on those features that the healthcare system will need to implement in order to improve on their priority dimension by learning from the invited healthcare system. So they can enter there the name of the feature, whether it's already partially implemented, how feasible it is, and what adaptation would be necessary in order to make it possible. And of course, save at the end. So this would record their decisions as to what they would need to do in order to improve on the particular priority dimension by learning from the invited healthcare system. The next step will be to capture action plans, which will reflect the rationale for twinning and coaching, inform about problems to be solved or informed by it, make recommendations or agree actions to be taken, inform decision makers about the priority actions that are necessary, and list lessons learned from the twinning and coaching. This wasn't part of the Sirocco project, however, it will be implemented as part of the knowledge management hub that we are developing during the Sirocco Exchange project. And I will pass over to my colleague Tamara.
So I'm going to explain the user's experience of using the Sirocco tool. So within the Sirocco project, we have tested the Sirocco tool in 5 European regions: Olomouc in the Czech Republic, Norrbotten in Sweden, in the Basque Country, in Puja, Italy, and in Scotland. So in order to gather all this experience of the professionals using the tool, we organized different focus groups in each of these 5 regions. So the objective of this focus group was to capture the experience and the lessons learned as well on the Sirocco tool, on the different functionalities of the tool. For the self-assessment of the context,
for the assessment of the good practices, and for the process of tuning and coaching. So we conducted different focus groups for each of these functionalities. I want to present all the lessons learned from this project about the use of the tool itself and the process of using it. The key findings and messages are that the Sirocco tool facilitates a constructive collaboration between different professionals, facilitates also the consensus building. So they meet to talk and discuss on a particular context, good practice, on a process of knowledge transfer. The Sirocco tool also enables dialogue, generates knowledge, and promotes reflection on the object of analysis, either if it's a good practice or a specific context. The Sirocco tool also provides support to make decisions or to present rationales to decision makers with regard to integrated care. In regarding to the future uses or wider implications of using the Sirocco tool, the attendees in the focus group highlighted that the Sirocco tool can be used in a great diversity of organization, also at different organizational levels and system levels, and with different stakeholders. Also, particularly, the Sirocco tool was found useful at high organizational level, for example, from a strategic perspective or with managers and decision makers. The Sirocco tool has been found potentially useful in terms of determining areas of policy making. In regard to our next steps, I would like you to invite you to our next workshop. Will be held now at 9 o'clock. I don't know which room, but I can tell you now. So we have granted with a continuation of the Sirocco project called the Sirocco Exchange, in which we are going further on the Sirocco tool. So we are developing a knowledge management hub, which will be helpful or try to facilitate the implementation of action plans in those regions that have move forward in improving their integrated care. So thank you for your attention, and I let here our emails. In case that you have any questions, you can always send us an email.
Thank you very much.
Further talks this morning. Has anyone got any questions? Got 5 minutes for any questions. Any observations or anybody doing similar things? What struck me was all three talks was about improvement, and the improvement in to someone's life. And although it was either research or tools or the concept of frailty and improving conditions for patients, at the end it's someone's life that we're trying to improve. Was it from the tool point of view, is it difficult to try and get people on board to use it?
No, not at all.
No.
We have people registering on the tool almost every day.
Right.
It's very popular. Yeah.
And we are translating the tool in 5 or 6 different languages in order to involve different professionals that work at field level to use the tool. So, yeah.
Great. Anything else? Well, I guess we have time for coffee before 9. Thank you so much for coming this morning, and thank you guys for sharing your work.
Thank you.
It's been great. Thank you very much.
Okay. Thanks for moderating.
Based in Spain, and I've been asked to chair a few sessions at the conference. So we're starting this morning with population-based health strategies. Unfortunately, one of our speakers is missing. Perhaps he's having a cup of coffee somewhere, I don't know. But I'd like to introduce you to David Cedeño, who's from the Madrid Community Health Service, and from Geert Benschkens from the Flanders Regional Health Authority. We have Ramouj and David from the Imperial College London, and we have, sorry, Mark, I'm only allowed to say Mark, who's also from Belgium and Health Authority. So perhaps we could start, David, with your talk. David's speaking in Spanish, but later we can have questions and help with any language difficulties if we need to. So we'll stick to the talks, and then at the end we'll pull together our questions and our debate. Thank you, David.
Buenos días.
Good morning. Thank you all for coming. I would like to thank ISIC and the Scientific Committee for picking my talk. I'm going to start straight away with it. Its title is the Clinical View of the Healthcare Professional. In Madrid, we have more than 50,000 healthcare professionals, 34 hospitals, including monographic, supportive, hospitalization and conventional hospitals. We have 428 primary care centers, of which 265 are primary healthcare center, and the rest are local practices. Currently, we have over 6 million citizens with an individual healthcare card. The comorbidity and the number of patients with chronic diseases, we know that by 2050 will account for 1/3 of the population, which will be over 65 years. On your right, you can see how the population pyramid is reversing. In Spain, the current life expectancy is 83.1 years, and studies forecast that by 2040, Spain will be probably the top country in life expectancy with 85.8 years. Currently, the region of Madrid is the region with the highest life expectancy in Europe. Epidemiologically speaking, the prevalence of chronic diseases is growing, and the multimorbidity is increasing also with age. So the older the citizen, the more the chronic diseases and the higher the multimorbidity with diseases such as kidney failure or heart failure or diabetes. This kind of patients have a high hospitalization burden and have an impact on the economy and the healthcare system. There are several studies showing that the public expenditure for these patients is higher than 75%, and the causes of death are higher than 60%. If we want a universal, sustainable, and equitable healthcare system, we need to readjust our systems towards cost-effective intervention systems which address those target populations. These interventions must be proactive and adjusted to the actual needs of patients. So what is the action when approaching chronic patients in the region of Madrid? Well, as in the national service and the same as in other regions in Spain, we are conducting population stratification and risk adjustment models. There are several indicators and groupings in Spain, ACGs, CRGs, etc., which are predictive risk models. These groups group the general population by strata, and they score the level of risk of individuals. The region of Madrid decided together with the ministry to work with other 13 regions and use this adjusted risk level. So what Madrid did was introduce a number of data with all the active chronic episodes and those which were closed in the last years. Also the active acute pathologies in the last year and cancers, neoplasies in the last 2 years. And this is coded also with CIE 9 and 10 with data from the last 4 years. We also include demography data, including age or sex, which allow to stratify the risk of the individual citizens in the region of Madrid. With those data, we have an onset database classifying the population according to the risk level. Level 0 without a relevant chronic pathology, and then levels 1 to 3 levels. 1 is low, 2 is medium level, and 3 is chronic patients with high risk levels. The region of Madrid uses the permanent Kaiser pyramid, where chronic patients are classified by the acuity of their disease. Those with the most acute diseases are classified with a high level, then we have a middle level, and then low level patients. This is the current populational stratification in the region of Madrid. 55.54% are citizens with the relevant chronic disease, which is almost 4 million people. And then we have 44.46% of people without a chronic relevant pathology. Around 3 million people. The total of the population is 6,749,000. So, with a high level of risk, we have 180,000, a little bit more than 500,000 patients, which is 15% of those chronic patients which have a medium risk, and those with a low level, which accounts to around 3 million people. What did Madrid do to change all this? Well, we introduced the view, the perspective of the healthcare professional. Up to now, the risk levels have been evolving towards levels of intervention where the primary care portfolio has been adapted, and the strategies of the region of Madrid have also been adapted. This means that there is now a new approach in the care of these chronic patients. Here we can see the evolution. It all started in 2014 with the chronic strategy. Then there was a first stratification in 2015. Then the level risks have been incorporated. Then in 2016 there was a second stratification. The portfolio was adapted to the stratification. Then there was a communication dissemination plan in 2017, and in April 2017 the primary care professionals started allocating the intervention levels. There was a third stratification in 2018. There have been also integrated care processes in 2019, and currently we are validating. We hope that by the end of this month we will be done with the fourth stratification, including data from 2018. So what is the intervention level? It's the level that the doctor and the nurse in primary care allocate to the patient according to the information given by the grouper and also by the knowledge that the healthcare professional has on that patient, the social, family, economic, functional, cognitive, and self-care situation. So we take risk levels as a system for supporting decision-making. But here, the health knowledge is of great importance, including also the assessment made by the healthcare professional. So we've moved from a static stratification to a dynamic stratification where the medical healthcare professional and nurses also gain a more predominant role. Not only that, but also intervention levels determine certain roles, tools, and services that are at stake now in this care model focused on patients with relevant chronic diseases. This is more relevant with self-care. We are talking about active patients managing the disease. For medium-risk patients with high-risk patients, we have to provide more care. So what is the goal of Madrid with all this? Well, we want to include the view, the perspective of the healthcare professional in the populational stratification by allocating intervention levels that activate interventions and actions according to the actual needs of the patients throughout the entire care process. We also introduce a dynamic level, which is very important, where the healthcare professional reassesses in an agile way and assigns, allocates an intervention level according to the care situation. So they generate a stratification model that can be supported by all the integrated care processes that provide very high levels of quality as they establish where, how, and who is the most suitable healthcare professional. Therefore, the needs are adapted according to the intervention level. Primary healthcare centers are also adapted according to the needs, and we promote shared care, which is now more adapted to the patient needs, focusing more on the most severe and most complex patients. We also foster innovative and proactive processes and actions that aim at fostering the autonomy and involvement of the patient, trying to avoid hospitalizations. How do we do that? With proactive follow-ups, alternative specific circuits, and different types of nursing cares. We also provide a service portfolio in primary care which is adapted to these levels of intervention. We activate certain actions according to the intervention levels that have been assigned. The region of Madrid is reviewing the stratification that was made with GMAs and is now allocating new intervention levels, but it is prioritizing those patients with highest levels of risk, patients that are based on the complex chronic patient pie, where the care process is prioritized over other patients. It's important to remember that patients are individuals with different needs, and therefore the actions on each of them may be different. The region of Madrid has also developed a visual alert system in all its computer systems that allow all healthcare professionals in the network to visualize the levels of intervention in real time. What are the data we have in Madrid? We have data on the stratification by level of risk and then by intervention levels. This is something I have shown you before, so I'm going to go on. The stratification by levels of risk, here we have some data about the 6,700,000. We've prioritized those patients with a 3 level of risk, which accounts to 180,000 patients. The healthcare professionals have reviewed people with the 3 level of risk, and they've reviewed 66%, 48% of the mid-level, and 34% of the low risk. This started in April 2017, and we are currently given a high intervention level to 18,000 patients, a medium intervention level to 100,000, and low 3 level, 1 million patients. So we believe that in Madrid, classifying patients according to intervention levels given by a healthcare professional suits intervention better for the patient's needs, especially those patients which are more fragile and more complex, because we include the multidimensional perspective of the patient's situation in their environment. We believe it's fundamental to have healthcare professionals involved in this model. In order to continue, we need to have more relevant conclusions on this care model. Finally, I would like to mention that we must go on in order to overcome obstacles. If we manage to do that with energy and passions, we will meet our goals with passion. Thank you.
Sí.
Gracias.
Okay. Good morning. My name is Geert Peuskens, and I'm presenting a presentation on regional strategic care planning, and the focus is on general hospitals. So it's a bit of a different story than we heard till now. Flanders is a region in Belgium with 6.5 million inhabitants. We have 53 general hospitals on 99 sites and 29,000 hospital beds. If you compare it with other regions in Europe, it's really on the high side. And yearly we invest 200 million in hospital infrastructure. the goals that we want to get with our regional planning is align the care supply to the actual needs of the population and stimulate cooperation between hospitals and other care providers. We want to pool expertise, and particularly for complex pathologies, and also match the expenditure to the financial context and achieve a health economic justifiable offer. To do so, we made a new approach of strategic planning, and so all the hospitals are centered in 14 networks or potential networks, and those 14 networks have to do 4 steps to become to get a regional strategic plan. The first step is they have to make an inventory on population needs and the inventory of the care partners in the region where they are active. They can use demographic figures, but also health indicators and the ratio of hospital admissions in their region. In a second step, they will do a simulation. There were some studies in Belgium about the number of hospital beds that will be needed by 2025, and the conclusion, if you translate it to the level of Flanders, was that there are about 6,000 beds too many in Flanders. And the University of Leuven has figured out and made a tool to see how many beds there are too many in each network that is forming and on the level of each hospital. In a third phase, they have to do a comparison between the current and the required care capacity. And it's beds, but there are also other care programs and so that are included to see what is the gap between what we offer at this moment and what do we have to offer in the future for the needs of our population. And in a fourth step, the hospitals in each network will have to negotiate with each other on which care programs they are going to make and which functions they need to be able to answer the needs of the population. But at this moment also the other care partners in the region will be included in the conversations to see if there are possibilities of changes and less hospitalization and more ambulatory care. We are going to use it to plan and recognize hospital functions, care programs, services, but also for the financing of infrastructure of hospitals. So above you see the figures from our first slide. And where are we going to? Well, we want to go to hospitals of the future. Hospitals of the future are smaller hospitals. You can see we think we need 23,000 beds by 2025, and that there will be a change to more ambulatory care. That can be ambulatory care in the hospitals, but also ambulatory care outside the hospitals and other sorts of care than we know now in Flanders. Hospital of the Future is also a hospital that has a strong focus on technology and highly specialized care, where we try to keep the patients that don't have to be in the hospital out of the hospital. And it's also at the end the phase to consolidate the 14 networks that are creating at this moment. What are the lessons learned at this moment? Well, in 2019, so this year, we are implementing this new way of organizing. So it's really a long process to go, and we see that there are a lot of problems and things we have to adjust. It's also that at this moment there is a focus on the hospitals, but in the far future we want to have all the caretakers in a region sit together and think together about how the regional care plan should be for that region. So that everyone has the same level of interaction and same weight in the decisions that are made. New trends in the cooperation will need also new business models and financing mechanisms. And there, for Belgium, for Flanders, there is a problem because the financing of the hospitals is on the Belgian federal level, while other parts of financing of the healthcare system is on the level of Flanders. So if we gain money by the hospitals, it's not sure that we can use that money for parts of healthcare that are the responsibility of Flanders. And one of the things we need are indicators to optimize to ensure the optimal and cost-efficient hospital and primary care planning, and we have the impression that we lack those indicators at this moment. If there are further questions, here are our emails. The presentation and the poster are at our website, but we have also some copies here, so if you're interested, you can pick up after this session.
Leiden University. Thank you.
Good morning, everybody. Well, thanks for the organization that we have the possibility to say something about the new master's program that we are developing at Leiden University Medical School. My name is Mark Bruinzes and I'm responsible for that. Why a new master's program on population health management? Like you heard in the two previous presentations, we need some new professionals that know how to handle population health in the future. So we thought, let's make a new educational program for it. That's going to be, well, it's located in The Hague from Leiden University Medical School. The Hague doesn't have its own university, so there's a close collaboration with Leiden. And Leiden is the oldest university in Europe, so we thought, well, let's do something new, innovative over there. We make a new master's program. But if you make a new master's program for new professionals, you first have to think about the work field that the professionals are going to work in, your graduates are going to work in. So we need new competences. So we were looking for what do these new graduates from this new master program need to have in their baggage when they leave our education. We've looked in literature. I found one study that said something about competences for population health management, and we had an expert meetings of possible potential new employers. People from science, because it's also a research field, managers of healthcare institutions, including health insurers in Holland, we have a Bismarck model, and healthcare professionals. So we came up finally with 5 types of competences that we thought that the new healthcare professionals should have. They should have knowledge and skills on population health management, so they need to be an expert. It's a data-driven approach, so they need to have skills and knowledge, but also an attitude towards data. Then we have 2 areas which can be called skills and attitudinal on transformational skills and eclectic interdisciplinary skills. And we think it's very important, together with them, with the employers, that they have some personal effectiveness. They should have some personal leadership to convince in that very strange field of healthcare where you have a lot of competing interests at the table, that they know how to deal and know how to handle those different interests with each other. Very briefly, a population health management expert, reasons always from population needs, as you saw here in the previous presentations, but he's also able to create an integrated interprofessional overview of health issues, including solutions and effective communication towards all stakeholders. And he knows the essential ingredients of population health management. If you look at transformational, then you look at what the new professionals in healthcare should have. Healthcare is is an ever-changing story. It never stops. In 5 years' time, nobody knows how the world of healthcare will look like if you see with all the developments that are coming. So we think it's very, very important that the new professionals have an attitude that they are not only professionals, but they know how to deal with the transformation. So they need to have an attitude to act effectively in a continuous changing context. Being able to identify in an early stage demographic and epidemiologic developments, and they have to create an attitude from reactive to proactive response to these needs. Now, I told you already, and you saw the data-driven aspect. That's, I think, for everybody familiar. The data is not only about quantitative data, but it's also about qualitative data. What matters to the patient, etc. So they have to know how to collect and identify data from various sources and scientific domains, the mixed methods, the linkage problems, everything that comes along with using data of various sources. And next to that, and that's in the last bullet, they have to know how you use data when you're improving your programs. So they know how to have something like performance management and stuff like that. Since it's not only a medical field or not only a business field, it's not only an economic field, it's an interdisciplinary field where we work in. So the students need to have knowledge about the healthcare issues from various perspectives. They have to realize and evaluate they have to know how to realize and evaluate efficacious healthcare organization. Aggregate knowledge from various perspectives is very logical then. Then I think it's very important, we think it's very important that they have to know the different interests and how to handle the different interests of the various stakeholders. So they have to develop some kind of political sensitivity. And finally, they are not just an instrument, they're not a robot, they bring themselves to the table, they have their own personality, so we really think it's crucial that they have to be at the table as not only as an observer, but also as an actor. They have to communicate and present effectively in a common language to all stakeholders. They have to talk with the alderman in the municipality, they have to talk with the specialist, with the healthcare insurer, they have to talk with all those people. Well, that's what we are building. It's an online master, or it's a blended master with a large part online. The first MOOCs are already there, so if you like, you can follow it. It's free, available on the Coursera platform. The first MOOC in the coming years, there are 9 MOOCs coming out on the Coursera platform, so everybody can then find out what you need to know about population health management. Thank you very much.
Thank you, Ramanuj. And oh, you're the first. Okay, thank you.
Thank you. Thank you for coming to hear us talk today. My name's Dr. Ramanuj. I'm from Imperial College. I have my colleague, Dr. Shirlene O, in the audience. So I'm going to talk first around how we're using kind of big data in Northwest London. And then I'll call my co-presenter, Dr. Barai, to talk about some of the practical aspects of how it's actually being used. So a little bit about who we are first. Imperial College Health Partners, we're an academic health science network, which means that we're a partnership organisation that brings together NHS providers, clinical commissioners of health services, and some leading universities across Northwest London to look after a population of about 2.2 million. And we were set up to support innovations that can help solve pressing problems by collaborating across the health sector. And one large project that we've been involved in has been on the use of data analytics to help case manage patients that require more targeted and proactive care in Northwest London. So we call this Whole Systems Integrated Care, or WSIC for short. I don't want to spend too much time describing it because Kush will take you through it in a bit more detail. But in brief, we've managed to collate all the contacts that our residents in North West London make with GPs, social care, community care like district nursing, inpatient hospitals, specialist care like mental health, into one accessible, de-identified data warehouse. Kush will take you through how WSIC is being used in his region in North West London. But before he does, I just wanted to outline some kind of theoretical constructs that underpins how we thought about WSIC and how it could be used. So we consider WSIC to be this thing called big data. And what is big data? Well, big data is a pretty nebulous concept, but what it essentially means is bringing together multiple data sources to generate more information than would be possible from just looking at each of these data sources on their own. So the interesting part from my perspective is how do you do this? The analytics part, if you like. And the idea of big data analytics is generally divided into three main categories: descriptive, predictive, and prescriptive. So descriptive analytics is where most organizations start. This involves the majority of healthcare data like clinical records, patient surveys, lab investigations. It tells us what has already happened and can answer some basic questions like how many people acquired an infection in ITU last year. And while this is a good first step, there's only so much you can do with it. You can't use it to forecast what's going to happen. Predictive analytics is the next step. It's the ability to extrapolate the course of future events from descriptive data. To be able to do this with any degree of reliability, you require large volumes of real-time data. And this is where big data comes in. And then the next step after that is prescriptive analytics, which is an even loftier goal. This doesn't just answer the question of what is going to happen. It can tell you what course of action would produce the highest likelihood of impact for your patients. So how can we move from descriptive to predictive to prescriptive analytics? To be able to do this, you need to use data intelligently, and so you need a strategy. And if you want a strategy, you need to have leadership. So we ask leadership to identify 6 key questions on how they use their big data. First is, what are the important data sets involved in care quality, and can you join them up? Secondly, by joining them up, could you construct a meaningful narrative from your data? Thirdly, if you can construct a meaningful narrative, can you use statistic methods to make sure that your narrative is valid and reliable? Fourthly, are you going to be able to present this data in an understandable way? Fifthly, does the information you present, is it helpful in making good decisions? And finally, once you've accomplished all the other goals, can you deliver the data and the information in a timely fashion to the people who need it most? So what I hope this demonstrates is that data is only a tool. It's just one step in your journey to being able to achieve meaningful change. And at ICHP, we use the population health management methodology to think about how to use data. And so I'll just briefly take you through this. The first step is to analyze your local population, identify the health status and who actually needs to be targeted. The second step is to identify the outcomes that you want to achieve for your target population, whether that's reducing service use, improving clinical outcomes, and then you need to use the data analysis to think about your populations at 3 levels: whole populations, subpopulations based on need, and segmented or risk profile populations, to think about how you can use predictive data analytics or predictive risk modeling. But then the important part is, once you've identified the populations you want to target and why you want to target them, how you can target them using predictive analytics, you then actually need to do the hard work, which is around the change management. You need to be able to incentivize the changes that you make. And this involves aligning financial incentives, but it goes beyond that as well. You don't want to have a push-down mandate where you just tell everyone what to do, but you need to have a vision and you need to have a strategy that takes the people that are actually going to implement the change with you. And so this calls for leadership. So building such a big data analytics initiative with prescriptive insights in mind can be complex and challenging, but there are prizes to be won every step of the way. And so hopefully Kush will now talk you through how that's actually being used in Harrow.
Thank you, Ash. So I'd like to now just give you a snapshot about how the WSIC dashboard is used in its practical application, and also maybe a bit of crystal balling about what its potential could be as well. Harrow, just briefly, is in northwest London. It has a population of 240,000 people in total, and back in 2016 it committed to going on an integrated care journey. So the CCG, which is the health commissioners rather, providers, and the care commissioners, the local authorities, came together and said that we want to do things differently, we want to collaborate together, we want to align outcomes with payment incentives, and we also want to take a population health management approach to how we deliver health and care in Harrow. And part of that was to try and utilize this tool, the Whole Systems Integrated Care Dashboard. And so what you see before you is actually what the dashboard has done is segmented the population already, and it has pre-arranged segments. You've got the healthy population, you've got older adults with one or more long-term conditions, etc. And we wanted to bespoke that to Harrow. We wanted to understand where we want to start in Harrow in terms of integrating, and part of that was understanding, well, where's the greatest need at the moment, and where can we make the best impact in terms of collaborating. And so what we were able to do is extrapolate the data which sits in the dashboard according to segments that Harrow wants to start in terms of integrating care. So we felt that we want to start where the need is greatest. So your high users, the multimorbid, the frail, the patients who are end of life, care home residents. These are all patient cohorts where you can recognize that there's going to be multiple contacts across various providers, across various teams. And what the dashboard was able to do for us was essentially not only identify the numbers that we're looking at in terms of those cohorts, but also the total health and care cost utilization for those patients at the moment. So we had a good starting point, a baseline for what we might need in terms of resource. And just to give you a bit of a perspective, in terms of Northwest London, as opposed to Harrow, the dashboard's able to give us a demographical split of patients. And I'd just like to draw your attention to, if the pointer works, that Harrow has proportionately a high number of patients over the age of 65, where we know healthcare utility starts to increase going forwards. And hopefully this starts to exemplify what potentially the dashboard does allow us to do. So as a clinician, I'm looking at this, and this is a screen dump from the dashboard. It's the frailty radar, and there's various other radars. There's radars by condition. This happens to be obviously according to frailty, and it's able to give us an idea of so that's blanked out, but there'll be patients across there, and then it starts to demonstrate different ways in which someone might be potentially frail. So you've got unscheduled attendance, you've got whether a patient has a high BMI, you've got the number of falls that they've had in the last 12 months. So it's a snapshot of all these various different components that collectively aggregated give you potential severity, potential user need, and that's incredibly powerful, because then you start to identify the patients who you need to potentially intervene with sooner and with greater pace. And as a primary care physician, as a general practitioner, this is really, really interesting because I often say line of sight is so narrow. What I see in front of me as a clinician is someone who can attend my consulting room, but you've got all these individuals who potentially can't attend my consulting room, but they're going back and forth into hospital, they're having falls in the community, and so what this dashboard starts to do is broaden my line of sight into patients that have a greater need. And following on from that, the other very powerful tool that the dashboard has is, this is an individual, again it's anonymized, but it's an actual case. This is one individual's dashboard, and it's been termed Theograph after Theo Georgiou, who's a senior researcher at the Nuffield Trust, who initially conceptualized this and talked about this about 9-10 years ago, but what the dashboard now starts to do is it automates it. So just to orientate everyone, sorry, beg your pardon. One second, sorry. You've got timeline across the horizontal axis. You've got streamlines, and these are all various individual providers and functions. So there's quite a lot of primary care swim lines, but there's also community intervention. So that's district nursing, that's occupational therapy. You've got the acute providers there as well. So that's the hospitals, and each line represents a contact. Now, illustratively, immediately you can tell how impactful that can be when you can start saying, well, actually, if this individual has got several non-elective admissions there, what happened before then, or what didn't happen before then, in order for that individual to then subsequently end up in hospital on subsequent occasions, on multiple occasions, and again here as well. So you can now start utilizing data, and as a clinician, it becomes very impactful when you can see it in that format, and that's just one example of what the dashboard can do. It's not the panacea, and it's just the start of utilizing data and illustrating it in a form which can help clinically. What are the next steps? Well, despite there being several providers that are aggregating data into the dashboard, we recognize that there is other sources of data, notably data across the wider determinants of health, social care, housing, access to healthy meals, nutrition, employment, education, which we've probably not tapped into yet. And that probably falls into the next potential future outlook, which is starting to see if we can actually tap into unstructured data, which I feel would exponentially increase the impact and the use of this sort of thing. Remember that the data that currently represents in the dashboard is based on coded data, and coded data is based on the person who codes it. It's incredibly variable, and that's not only between providers, but within providers themselves. Individuals will code differently. But once you start tapping into the unstructured, uncoded data, then we potentially can move from the descriptive data analytics, which Ash talked about, to hopefully predictive and even prescriptive analytics. Any questions?
Go on to the last session and then have all
yes,
the
of course,
questions.
yes, of course, yes.
Fine.
Thank you.
Okay, thank you.
Good morning, everyone. My apologies, I'm not mic'd up, and as a sports fan, I've got screen envy. It's just amazing. I'm going to talk with you about some of the work that my colleagues have spoken about, but at a systems level. My name is Frank Tracy, and I work for Children's Health Queensland in Australia. Just a quick snapshot of the Australian population. While that's up there and you're having a look at that, I'll talk to you a little bit about what I'm going to run through over the next 15 minutes. As I've mentioned, I'm going to look at a systems perspective and how we've brought data to life to inform clinical services planning and services planning across a system of care. And we've done that using the social determinants of health as a prism, as a new way, well, as a way to think about planning and delivering services that are really impactful and that shift the way we think about health services for the future. Over the past couple of days, I've been struck by how many hospital beds we're building. And I think we need to get some proportion in our investment around how we actually work in communities to prevent the investment in hospital beds for the future. I'm not saying it's an either or, I'm saying it's an and. So the Queensland population, this is what it looks like for children living in Queensland. My apologies for the grey type font, but we've got about 1.3 million children and young people between the age of 0 to 18 years. This snapshot tells you what it is that you need to know about growing up and living in Queensland. It's a vast state. We are challenged by the tyranny of distance, and we're challenged by the fact that up to half of our population live in rural and remote areas. So I read some statistics yesterday. Apparently, Queensland, the state of Queensland, is 5 times the size of the state of Texas. What we've decided to do is to take a different approach to the planning of services for children and young people. Children's Health Queensland is a unique hospital and health service. We're one of 16 in the state of Queensland, but we have a statewide remit to deliver services across the state and to support capacity building with our other hospital and health services as they deliver services to children and young people closer to home. This slide, I won't speak to the detail, I'll let you read that. But what it does is that it speaks to the social determinants of health. Heckman's work is probably best known among you, an educationalist, a Nobel Prize winner. I just draw your attention to the graph on the left-hand side. This was one of the graphs that really, this was one of the images that really struck me. And as an executive and as a lead for planning and strategy for an organization, this really did speak to me. If I think about the opportunities that are afforded to children across the social spectrum. If we look at the investment in childhood, it's a smart investment to invest early. It's a smart investment to invest in prevention. Unfortunately, our system tends to be shaped much more like this. And it's difficult to navigate those silos. It's even more difficult to work within them at times. In Queensland, what we have is a government that's future-focused. Our Premier has a list of priorities. There are 6 here. In our planning as a statewide service, we have aligned our work to the work of our government. We have identified very, very quickly and very intentionally those priorities that we will focus on for the next 10 years. Not only at a state level, but at a federal level, we've also used the information from the federal government and reviews by the federal government to inform our thinking and our planning. So the picture I'm trying to paint for you here is we're taking a broad systems view and using the social determinants of health as the lens on which we will see the planning and delivery of health services for our children. You'll be familiar with the quadruple aim. Again, we want to build an evidence base. We want our processes to be based on the best evidence. We have an integrated care process that we use. This was designed specifically by Children's Health Queensland, again using the Canterbury model from New Zealand as its base. But moving on to the most important part of the presentation, the very first and most basic component of planning for health service delivery is understanding the need. Then we need to think much more about planning for outcomes, not planning for outputs in an activity-based funded environment. Then we need to think about delivering on those outcomes. What does that look like? What does that mean? We need to measure those. And then we need to feed that back into understanding the new set of needs. And can I tell you, for most of you in the audience, I'm sure you'll understand this, that each community, each village, each community has its own specific needs. So a cookie-cutter approach to planning, a cookie-cutter approach to delivering services and building systems will not work if you are not cognizant of the need to be flexible and to create systems and services that are accessible to populations, because each community's needs are different. I've mentioned how we've built on the social determinants of health, and the World Health Organization provides us with a very useful, succinct definition of that. I won't dwell on this, but I'll illustrate to you what it is that we have done with that work. We have taken those social determinants and we have used a federally mandated approach. It's called the NEST framework. We've used that approach that brings to life the social determinants and focuses on outcomes for children and young people through the life journey. We've created a series of health indicators based on those social determinants. So sitting behind those, we've got about 170 different indicators that we can measure in terms of the impact of service delivery on a child. We further refined that and we've identified the 7 factors that impact and affect a child growing up in communities in Queensland. These are all the social determinants that you'll be familiar with: learning, being healthy, being loved and safe, using services, having material basics, and participating in community, making friends, growing up, having a neighborhood, playing sports. All of these impact significantly on the health and well-being of children as they grow. Again, I leave you to read this very briefly. I'm aware of death by PowerPoint. I've got way too many in here. But what we've done is that we've taken large-scale data sets from government agencies. And like my colleague mentioned earlier, we've done some analysis of that. So I've taken the 80% of the data that we report on under our contracts with government. And I've asked a series of government agencies to contribute their data sets to us at Children's Health Queensland. We have then collated that data, analysed that data, and created a narrative that our clinicians and our communities understand. So we have 32 different data sets from 12 agencies, and we are now able to predict with a relative level of accuracy the life lived for a child in the 528 statistical area 2s in the state of Queensland. Now, statistical area 2 is a population anything from 3 to 25,000, but it sits roughly in that 10 to 20,000 mark. So we are able now, with a degree of accuracy, to talk about the life of a child in that community. When we bring this data to a local hospital and health service, they're able to plug their data into this system, and it will give them an even more granular picture of how their population is accessing services, both hospital and community. In terms of using the data, we've been very intentional about how we've targeted it. So we've used CEFA, socioeconomic data, we've used census data, and a range of other data points, including domestic violence, attendance at school, so educational data is pulled into the mix. I'm rapidly going through this, and this presentation will be available for you after the session, but I want to get to how we make the data speak. My colleagues spoke about creating dashboards. Well, we have built that function. So we create dashboards that are live dashboards. We use ClickView. We are able to zoom into these, zoom into specific communities, look at the profile of that community and how it's shaped. But the key to this has been our ability to create a compelling narrative for the life of a child growing up in any one of those 528 SA2 areas in Queensland. This is what it looks like. So this graphic asks more questions than it answers, and that's the intention. The intention is to pull the data and make it meaningful. The intention is to look at the stats that 1 in 7 women in Queensland smoke while pregnant. The data tells us that 94% of children aged 5 years are fully immunized. There's a worrying statistic that 1 in 4 children start school with significant developmental delays. So that data is pulled directly from the education data from the national data set. The power of this is that when we sit in a room with our colleagues from other jurisdictions, we're able to paint for them a picture of what their community looks like, what the life of a child growing up in that community looks like, and how our agencies are coordinating, or more often not coordinating, their strategies, their investment, and their care delivery systems. This picture is the life of a child growing up in Kingston, which is a metropolitan neighbourhood in Brisbane. I leave you to imagine what the life experience is for that child, and how we as agencies need to think differently about how we provide health and social care to support this child be the best version of themselves and achieve their potential as they grow up in these circumstances. I don't need to talk to this room about the importance of partnering, but it's critical. When we identify a child or community with a certain set of characteristics, well, we can predict with a degree of accuracy what it is that we need to do, and then we need to take targeted action. We must partner for success. We must do things differently. What we're doing is not working as well as it should. We're investing in technology. We're investing in hospitals. We're investing in different ways of doing things. And my goodness, we're reporting a sea of data across multiple government agencies. What we've done in Queensland, at Children's Health Queensland, is pull that together and create a compelling narrative that will help us think differently about our investment for the future. I'm just going to show you a short video just by way of closing that brings all of this together. It is the Children's Health Queensland Clinical Services Plan. We've used all of this data and this methodology to create this 10-year plan for the delivery of services to children in Queensland. Just trying to find some volume.
Health Queensland, we are passionate about leading life-changing care for children and young people. 1 in 4 Queenslanders are aged 0 to 19, and the number of children and young people in Queensland is expected to grow by 15% over the next 10 years. We know that the early years of a child's life provide the foundation for health, development and well-being across their lifetime. These foundations set children up to thrive and grow into healthy and resilient adults who live meaningful and fulfilled lives. Queensland's population is diverse, and our approach to children and young people's health and well-being acknowledges the interplay between people and the economy, the environment, their cultural norms, communities, families and peers.
Our vision of a healthier tomorrow means that we have a loving and safe home environment, access to material basics like housing, food and clothing, an enriched learning experience, a sense of community that we are engaged and participating in, proactive healthy behaviours like a good diet and regular exercise, and access to quality health services when we need them.
In the coming years, there will be numerous challenges that we need to address to keep Queensland's children and young people healthy and thriving. The Children's Health and Wellbeing Services Plan and the Aboriginal and Torres Strait Islander Health and Wellbeing Services Plan represent our vision for the future of health services for children, young people and their families. Children's Health Queensland has identified a suite of service directions and strategies that describe how our clinical services will adapt to meet the changing needs of Queensland's children and young people over the next 10 years. Our 29 strategies are oriented around children, young people and their families and aligned to 5 overarching service directions which represent our key areas of focus.
Promoting well-being and health equity.
We are taking a population health approach to service planning with a particular focus on reducing health inequities and directing services to those who need them most.
Improving health service design and integration.
We are designing and delivering our services in a way that is inclusive, easy to navigate, child and family friendly, and maintains the continuity of care across service providers and settings.
Evolving service models.
Our health services are evolving in line with the ever-changing and often increasingly complex health needs of children and young people, and we are driving greater consistency in approaches to child and youth health statewide.
Delivering services closer to home.
We are enabling safe and sustainable services closer to home through statewide capability building, delivering outreach and shared care arrangements, and leading the way in technology-enabled models of service delivery.
Pursuing innovation.
We are working with partners across sectors to drive improved outcomes and to incorporate existing and new technology into our services to improve the patient and family experience, clinical outcomes and efficiency. Children's Health Queensland is passionate about its role as a leader within a networked system of services, and our clinical services plans are an important step towards taking a more holistic approach to children and young people's health and well-being to ensure they can reach their full potential.
Thank you so much for your attention during the presentation, and I'm very happy to take questions afterwards, or if you drop me an email, I'm very happy to talk with you about some of the work that we've been doing and perhaps how we might be able to work together. Thank you.
Thank you. Before everybody starts, I'd like to kick off with a question. A little bit from the patient focus, or let's say people focus, because we're all patients at the end of the day at some point in our life cycle. In a population health strategy and the use of big data is going to be incredibly important to be able to change plan and take into context, I really like that whole aspect of taking into context the social environment. But at the moment, we're missing something a little bit, which I think is quite important. We already know that big data is working extremely well with social profiling and behavioral sciences. In fact, that's where it really kicked off with big tech industry. And in a way, we're detaching that from the clinical experience, the clinical data. And yet we know if we want to achieve behavior change in people about their treatment and taking ownership of their condition, whatever it is, we need to work with behavior. So I'd just like to know what any of you feel about that, and if you think that in the future you'll be taking in that data in parallel. Could someone give me some feedback?
Well, I think for the hospitals, in our model, we need data to make decisions. And we see that we don't have the data, or the data are not structured in a way that they can be used easily. So it's an important part to have those data. But on the other hand, we see that if we have to tell patients that we need lesser hospital beds, the population says, oh no, we need bigger hospitals, because when I go to the hospital, I want to have a bed, I want to have everything in my neighborhood and not a hospital 20 kilometers further. So it's a big change on both sides in the system and for the population.
So WSIC was developed before I joined Imperial, and it was developed by, I suppose, a partner organisation rather than Imperial itself, but we collaborate quite closely with it. But from what I understand, it was when the idea was developed, there was a patient group, and it was kind of co-developed and co-designed with them. I think, as Kush alluded to, there is and that group has intermittent kind of oversight with how the data is being used. Obviously, we needed to get the patients to agree that their data could be shared in the way that it was being shared, and so there was all those governance structures that needed to be put in place. There is a question around how you use that data. So one aspect of it could be, for example, because we've made it available to clinicians, could a clinician sit with the patient in front of them and kind of go, look, this dashboard shows me that you were, I don't know, going to your GP or your outpatient service this many times, and then something happened, you went to A&E, what was going on there, and kind of use it to open up those kinds of conversations. And I think that's an iteration that hopefully we'll be moving towards. I don't know, as a clinician who uses it, if that's something that resonates.
Yeah, following on from that, it's really interesting you asked that, because it's probably not directly answering your question, but not only is it translating the data to the people we serve, but then also our colleagues, fellow clinicians. How do you, I mean, I can't think of a GP who gets off on listening about demographics around the population, but then if you show them, for example, the timeline, the dashboard of their patient, then that adds to their sort of clinical discussion with their patient, and then it starts to hopefully open up those conversations where the data can actually facilitate that consultation rather than it be something that's depersonalized.
Yeah. And David, are you getting the translation? Yes. So from Madrid perspective, it seems you've got a huge population with chronic disease issues. And I wonder what kind of role is the patient taking on in responsibility for their own self-care with chronic disease. Can you achieve any behavior change with patients, do you think, looking ahead, now that you've structured the healthcare system to attend to them in a, let's say, a closer way?
Yes, with this change in our region towards a more dynamic stratification, which is now more focused on low and medium intervention levels, we are looking for more and more active patients. This is all focused on self-care by the patient, not only on the level of integrated care processes, but also on the level of other processes. For example, structured training. The region of Madrid has been developing structured training to clinicians and also to patients who are retrained to learn what they have to do.
Responsibility onto citizens now for the self-care is an essential part of our partnership in health between the healthcare system and patients. Do you have any questions amongst yourself first and then take it out? Or do you have questions here that you'd like to bring into the panel? This Tim.
I have two questions. The first question is addressed to the Jose or David on the stratification. Have you done any correlation studies or analysis whether those stratification models that you use lead to better outcomes that are people-centered, that patient value-centered? I'm just thinking along the lines of, are those stratification models you use demand-based stratification models, or are they supply-based stratification models? Because linked to what Chairman is talking about, there are behavioral needs, there are needs and wants of the patient. They are not necessarily medical. So how would we use stratification to segment the population so that we can target interventions to tackle non-medical issues? The second question is targeted at the visit group. Is it GPs alone that look at your dashboards? And are they competent, or are they comfortable to look at all the interventions needed that the data is throwing up to them? Because some of the data may come back as interventions that are beyond the GP realm. For example, crisis or, for example, acute care type interventions may appear in your data. So who looks at the dashboards, and are the people who look at the dashboards the same group, or there are multiple people looking at the dashboards?
You wouldn't do? Yes.
So in answer to your question, all clinicians in Northwest London can look at the dashboard, and you're right that I think some of what you alluded to is it a little bit of information overload, and it can feel that way for a lot of clinicians. In reference to the question around, well, obviously, if someone goes into a crisis, is that the fault of the GP, or if someone has a mental health crisis, is that the fault of a community provider, whatever it is? But actually, that's the conversation we do actually want to emerge from looking at the dashboard, because we are developing an integrated care system. So it's the collective effort of every partner in that integrated care system that should be saying, well, actually, are we as a group of professionals not providing the holistic care that we want for this individual? So it shouldn't be that it's targeted towards one or the other. But yes, in reference to your earlier question, it is a journey, and gradually more and more professionals are looking at their data. And I think it follows with, so in the last year and a half, we've had much more uptake of data that's going from GP surgeries into the dashboard. And with that, there was more interest. So you've got more GPs looking at it. But I've had colleagues who've spoken to me informally that other providers, for example, the Acute Care Trust or a Community Mental Health Trust, bar a few people who are involved in discussions around integrated care, have not looked at it, certainly not frontline clinicians, so a consultant psychiatrist, an acute care physician, a care of the elderly consultant. But as we try and work together, the idea is that it opens up more interest and more people look at it as a utility.
Any other questions? Oh, sorry. Yes.
Regarding your question, in the region of Madrid, we do have correlation data between the levels of risk and the levels of intervention. They are currently being validated. They are real data. And regarding the question about whether we've achieved so far, yes, we have a primary care network. We are extrapolating those data to the network to check whether the users are carrying out the activities. As I said, we have been using this intervention level since April 2017, so there is a relative progression. We started with the patients at a higher risk. We've reached 66% of level of intervention assignment, and now we're validating the data on the indicators level, which are the ones that are now more widespread in Madrid. Then there are also phone calls or follow-ups by the primary care centers, activities carried out with nurses, hospital admissions, and so on.
I've got a question, Dick. I find it fascinating that you've working with children and youth, because evidently, let's hope it should be easier, you know, to change behaviour and so on, and the social context. So as far as education is concerned around health and social well-being, is that very powerful also in this whole strategy by the government in Queensland?
Is the microphone working?
Could we check on his sounds?
Is it working? Yeah, thank you. As I understand your comments is around the importance of education. Are you thinking about health literacy for children and young people and families? Yes, critically important. But I would also reflect that health and well-being isn't the purview of health alone. So when we think about schools, when we think about communities, when we think about other parts of our social system, we have a job of work to do to lift and raise the health literacy of our communities. Parents, school teachers, early school teachers, the list goes on. So I'm hopeful that we are shaping our narrative to be able to do that. But I think that the biggest challenge that we have is that most of our institutions and in our ways of working are populated by people of my vintage. And that is problematic.
Yeah.
And that's where, in my view, we need to really focus our efforts. We have to think about shifting policy. We have to think about integrating thinking and bringing departments together who make decisions about policy. Because as we know, there is a policy lag phenomena. So the community, society they're rapid adapters, whereas our policy sort of trundles through the portals of government and will emerge maybe 12 months hence. So we've got a job of work to do to bring our generation on board with how things need to be different in the future and shape policy in that sense.
Do you have the digital capacity to bring together the information from different institutions? I mean, it's very widespread. So do you have a platform which is enabling the communication of data and input from
Yes, we have, but it isn't sophisticated at all. And I think that that's one of the challenges when one embarks on planning at a systems level. There's this notion that perhaps you need to shift legislation. There's this notion that perhaps you need to have some kind of, a mega capacity. In fact, we are reporting this information as government agencies and as health systems. We have all the processing power at our disposal. Currently, it's about focusing that. And I think our colleagues from the UK might agree with that assertion. Yeah, it is really about focusing it and about giving us a reason to pull it together in a meaningful way. Yeah. We have the capability and we have the capacity. It's about thinking differently.
And I resonate. I think it's interesting that it's not the technological limitation we're talking about. It's
human limitation.
It is, isn't it? Yeah.
It's always the human limitation. Any other questions here from the audience before we close? Yes, sorry, there's a lady here.
Thank you very much. Anya Carroll from Dublin, Ifig, Ireland. I think it's very easy to get seduced by the possibilities of big data. And I really like the idea that Frank said about using it to paint a picture. But painting a picture and making a compelling case for change is all well and good, but how do you actually effect that change? Do the panel have a view on that?
What I hoped to emphasize in my half of the talk was around the idea of data as a tool. And as with any tool, it can be used either productively, or you can ask ineffective questions of it and you'll get ineffective answers back. And I think that you're right in that big data has become kind of this buzzword, or the stratosphere of buzzwords, and people forget that actually it's just a tool, and the important thing happens afterwards around so when you've got your data and you've done your analytics, how do you actually do the change management? How do you actually redesign care? How do you bring your staff and your patients along with you? And that is a much wider and probably a bigger challenge than actually having the capabilities.
But it must help with the scope.
To scope out where to start, and also it's not a linear thing, is it? It's a cyclical thing. So you ask the question of your data, you implement change, and then you come back to it. That's something that it allows you to do. But provided that you have, for example, the leadership, the strategy, the idea of how you're actually going to use it.
Anything else before I think we're about to close now? But any other last comments? No? Okay, well, thank you very much. I find it fascinating personally, and I hope to discuss some of these things with you after the session. Thank you, everybody.
Okay, so finally we managed to start. So, well, thanks everyone for being here. This is bright. Thanks everyone for being here during the lunch break. This is actually, great that we have such a nice audience for this session. So, just a couple of technical announcements. So we'll run until 2 or a little bit before. We have 2 presentations so far. One is coming from Alaska via video, and then we will have a web connection for the person, so she will be able to also get your question for the last phase of the session itself. So the session actually, as we can see, is on creating the right culture for integrated care. I want to thank the organizer for asking me to moderate this session. I'm Michele Calabro. I work as Policy and Communication Manager for the European Health Management Association, EHMA. We are based in Brussels. We are a membership organization, and we work with IFE quite a lot on integrated care. So it's quite important for us to talk about this, because an essential part of actually how do you manage things at different levels. So again, just to remind you that if you want to interact with the, let's say, social media aspect of the conference, you can use the hashtag that you can see here on the slide, ICIC19 and integrated care. I will also ask to the speaker to eventually talk slow because we have the translation. So to help our colleagues up there, we will try to get this in different languages as well. So I think we can already actually start the session. So as said, we have 2 presentations. The first one is on creating a culture of improvement for integrated care. And I was saying we will have a video intervention from South Central Foundation in Alaska. And then we will have, after, also the possibility to connect with Michelle from the organization to ask her a couple of points on the video that you will about to see. So maybe we can just start the first video.
We changed everything. Alaska Native people knew that the hospital system was not working for us. And so we took over from the federal government and we began to own and manage it ourselves. Now we're South Central Foundation, an entity in the Alaska Native owned and managed healthcare system. We operate and manage services for 65,000 Alaska Native American Indians, and we cover a large geographical area, 60 communities, small communities. So who is South Central Foundation? In Alaska, we are the population that are walking a journey of wellness together with our providers.
Hello and welcome to Creating a Culture of Improvement for Better Care at South Central Foundation. I'm Melanie Binion. I'm a Senior Improvement Advisor for South Central Foundation and a customer owner. I've been with the organization for 21 years. Our vision at South Central Foundation is a Native community that enjoys physical, mental, emotional, and spiritual wellness. Our mission is working together with the Native community to achieve wellness through health and related services. This is very important to us as an organization, as we have to align ourselves with our vision and mission in everything that we do, in every change and innovation that we do across the organization. Our corporate goals are shared responsibility, commitment to quality, family wellness, and we have one more that is aligned with our corporate objectives and initiatives, and that's operational excellence. Customer ownership is very key in what we do. We went from being called patients to customer owners, and that is because we believe that we are owners in our healthcare and that we have a voice in everything that we do and the services that are provided to us. Our leadership principles spell out ownership, and we as leaders encourage ownership and responsibility, and that we share and listen to personal life stories, and that we improve for the future by learning from the past. Our operational principles spell out relationship, and we as Alaska Native people have been living this in our culture for many, many years, being in relationship with our community, with our family, and our coworkers. And we need to ensure that everything that we do for change and innovation is not only aligned with our mission and vision, but also our operational principles, and that we are in relationship with the customer owner, family, and provider, that we are intentional about the whole system design, and that we ensure that the hub of the system is the family, and that it's not complicated, and that the services and systems are built on the strengths of our Alaska Native people. Core Concepts is a 3-day training that is provided by a President, CEO, and Vice President of Organizational Development and Innovation. This is a mandatory training for all of our staff to attend. It's where we learn how to communicate with one another, learn to share and receive story with one another, and not only with one another, but also our customer owners. And we want to ensure that we are working together in relationship, that we are listening with an open mind, and that we are laughing and enjoying humor throughout the day. And I think this is very important, because if you're not enjoying your work, then this may not be the right fit for you in our organization. And we want to learn to share our stories from our hearts. In our old facility downtown, we had a system that was run by the Indian Health Service. And I'm going to share a story. This is where I received my care growing up. And this was not a place that we as Alaska Native people had pride, dignity, or respect in receiving care here. We were embarrassed. We did not share that this is the facility that we were going to. All of our services were provided through the ER. There was no family medicine. There was no pediatrics. So if we had an ankle injury or a cold, we had to go to the ER and sit for hours. So we saw an opportunity to change. And we started those conversations in the early 1990s with our customers and partners in identifying what can we do differently? How can we change our model of care? What could we keep? What could we throw away? And in 1998 and 99, when we transferred the facility from the Indian Health Service to the tribal partners and organizations, we made that change, and we changed everything. We changed our infrastructure and our model of care. We pride ourselves to be a customer-owner, data-driven organization, and we ensure that the voice of the customer is in everything that we do. And how do we do that? We do that through listening posts and through our annual gathering that we have in the community. We do that through tribal advisory councils. We have over 12 tribal advisory councils that we listen to, that goes all the way from our elders to our communities to our rural villages, and the village service management team and how we provide those services. We also have social media. We have a 24-hour hotline that gives access not only to our staff, but also to our president and CEO. And as I said, I am a customer owner. I've been with the organization for 21 years, and we have over 54% of our staff are Alaska Native and American Indian. We looked at many different ways to help improve the voice of the customer, and one of those was providing the surveys at the point of care. In the past, we would receive 4-page documents in the mail 6 months post-care. How would I know who I saw? What was the environment? What kind of care did I receive? So we put that in the hands of our customer owners, and we put iPads in each of our areas. And there's a 12-question survey that is immediately about the care that I received, the primary care team, and then we put that data right back into the hands of our workforce so that they could take immediate action and change what needs to happen for the customer owners. All of our employees are encouraged to innovate across the organization. And we start by providing this education and opportunity through new hire orientation. We've showed them how our strategic planning process works, how they can do innovation across the organization, who their resources are, and how can they do quick tests of change. We also make this as part of all employees' performance development plans. Improvement innovation is one of 4 workforce core competencies that we have in everybody's evaluation or performance development plan. And this is not only for our frontline folks, but it goes all the way up to our executive leadership. The READY model is our approach to change and innovation across the organization. This is a model that we use, again, to help ourselves align with our operational principles and our mission and vision. And we use tools and conversations throughout this model in helping meet our goals. The Model for Improvement is a tool that we have adopted from the Institute of Healthcare Improvement, or IHI. It's a quick and simple tool that we feel is easy for staff to learn and remember. It asks us 3 questions. What are you trying to accomplish? How will you know that a change is an improvement? What change can we make that will result in improvement? And it allows us to do quick, continuous change, showing us from current state to future state and our opportunities for improvement in between. Our PDSF form is aligned with this model for improvement and also is aligned with our operational principles. Again, with alignment of the operational principles of mission and vision, we have to question ourselves, why are we doing it? How does it affect our customer owners? If it goes against any of this, we then question ourselves, why? It doesn't mean we won't do it, it just, we have to stop ourselves and ask the question, why? Our organizational structure is different than most organizations. In most organizations, improvement folks are supplied by human resources, or it's just part of the workforce day-to-day operations. We value the importance of our staff and our skills and abilities to promote improvement and innovation, that we created a whole department and staff to focus on that. We have 30 FTEs in a department called Organizational Development that partner with our other divisions and departments across the organization. These 30 FTEs partner with Behavioral Health Services, Medical Services, Executive and Tribal Services, as well as Information Technology, Human Resources, or Development Center. And they live in that creative tension as partners when it comes to change and innovation, because we have to work out what's operational work versus improvement work. The improvement roles in our organizational development is the improvement specialist who really has knowledge of our improvement tools and methods, and they are leading improvement through the organization in partner with the executive sponsor and staff, and they are working at the department level for change. Our improvement advisors are more proficient in the tools and methods, and they're really advising and consulting with staff and others, as well as their direct reports, the improvement specialists, on how to make change. And they are driving teams and processes across the division and the organization. Our functional committee structure is another way that we allow change and innovation across the organization. The functional committee structure consists of staff, the workforce, from all 7 of our divisions that have a voice in change and innovation. And this allows us to make change immediately versus having to go all the way up to executive leadership. And they have granted us that authority in order to make change quick and easy. The planning and improvement linkages is another way to show how we are aligned from all the way from the mission and vision, operational principles, our corporate goals, the corporate objectives and initiatives, through our strategic planning tool and work plans, and then all the way down to the employee's performance development plan. Our corporate goal is commitment to quality. Our corporate objective is to improve workforce environment and employee development systems with an emphasis on Alaska Native people. Our corporate initiative is to improve retention of employees across the foundation. Our work plan is the HR committee annual plan is to improve retention by 1%. So as a manager in this organization, part of my evaluation is to see that the retention goal is an increase of 1% in order to meet that expectation. And if I have a 2% increase, then I have exceeded my expectations. The strategic planning cycle is based on our fiscal year cycle, which is October to September. And this helps us, again, align us throughout the model for improvement and looking at change and innovation, looking at our resources, our corporate goals and objectives. In January of each year, we do a SWOT analysis to look at how are we performing as an organization? Are we meeting our goals? How can we change that in the next fiscal year? How do we know that we are successful? We have seen a 36% decrease in hospital admissions over the years. We have seen a 40% reduction in ER visits. We have seen a 36% decrease in outpatient visits per 1,000 customer owners. We are also a level 3 patient-centered medical home, not only here on campus in our primary care departments, but also in the Valley and our rural locations across the state. We are consistently 75th to the 90th percentile for HEDIS outcome measures related to diabetes, cancer, and cardiovascular disease. We have also consistently shown a 95% to 97% customer owner satisfaction as well as employee satisfaction over the years, and 11% employee turnover. We are a 2-time Malcolm Baldrige National Quality Award recipient. In 2011, we were the first tribal health organization to win this award. And in 2017, we were the first healthcare organization to win this for the 2nd time. So what is the lessons learned? This takes commitment from leadership and workforce to make change and innovation happen efficiently and effectively across the organization. We encourage you to focus on workforce development and making sure that this is part of everybody's job. Don't be too toolish. As I showed with you a couple tools that we require our staff across the organization, we leave the improvement and innovation of other tools to be used up to them. This requires an investment. It takes time, resources, and people to make it happen. And it's not something that happens overnight. We didn't do this in a year or 2 years. This took us time. And don't be afraid to live in the tension. There's going to be a lot of creative tension in how you make change and improve as an organization.
Okay, so everything was fine and actually pretty interesting presentation. So we will have again the chance to ask questions to representatives of the center in Alaska after the second presentation. And the second presentation is from Caroline Nicholson from Mater Research Institute, the University of Queensland in Australia. The presentation is on culture trumps everything, the unexpected truth about building a frailty team across the continuum for a vulnerable population. So I'll give you the floor.
Thank you, everyone, and welcome, and great to have you here. We're on the right slides, that's good. Just a very quick brief about the Australian healthcare system. For those that don't know, we are a federated system. We have hospitals, acute hospitals funded by states, and we have the Commonwealth Fund. They fund primary care and a lot of aged care. So we have sort of like a 2-tiered level system. It'll start to make sense when I start talking. So what did we do and why did we have to do it? I'm the Director of Integrated Care at the Mater Health Services in Brisbane, and that's a number of public and private hospitals, both adult and maternity. And one of the things that we were experiencing was a huge increase in the number of presentations in predominantly over 75-year-olds in a 12-month period leading up to why we did this project. That's over 75-year-olds. In Indigenous people, we actually treat it as over 55. The expectancy of our Indigenous people is a lot less, something that we still need to work on. So why did we do it? Well, evidence does tell us that older people are at increased risk of suffering harm and poor outcomes as a result of a hospital visit. They have greater disability, they end up with falls, delirium, medical errors, acute illness, polypharmacy, you name it, we've got it. There's also evidence to say that hospital clinicians are spending more and more time and more resources on providing care to this very complex group of people. And also, frail older people the evidence has shown that they do respond well to rapid specialised emergency department based assessment to predict frailty and adverse outcomes. And we weren't doing that. People were coming in as normal to the ED and we were just going through the normal process. And consequently, they were predominantly being admitted and they were at risk of those adverse outcomes. So that was the problem. So what did we aim to do? We wanted to really look at what the problem was because we didn't have the data to say what our prevalence of frailty in ED was. We used the Rockwood Clinical Frailty Scale. There are many other frailty scales, and I'm not saying you should use this one, but that's just the one that we used, and we adapted it to fit our purpose. And we just wanted one tool that we could use both within the ED, within the acute system, and also, in our case, within aged care facilities, because we got them on board to look at when people were entering aged care facilities in our area where they were on the frailty scale. The population data related to Marta's older population, also in relation to not just where they were on the frailty, but their social situations, the geriatric syndromes and how many or what they presented with and what their utilisation of healthcare was. And we also wanted data on the effects of the particular team that we were going to implement to guide further development of pathways in the future. This is a very busy slide, you don't have to understand too much. It was really just to say this has happened over a period of time. We started in 2014 with what we call MACI, the Marta Aged Care in an Emergency. That was one FTE nurse who was amazing. And we really, at that time with one FTE, we just saw people coming in from aged care. By essence, people in aged care in our area in Australia are all frail. They generally, people used to go into aged care and be there for about 2.5 to 3 years. Now that's at about 18 months. They're getting older and frail when they enter aged care, and so by definition, when they are there, they all fit the frailty scale, unfortunately, but they do. So we had one FTE, we did the project for 12 months, we got a little bit of extra resources, and then we produced the paper, which you've got the reference for up there. And that was the outcomes of MACI, which I'll go through in a minute and tell you a bit about the team. What happened in 2017, we got an additional contract to do some additional work from another health area, particularly around presentations to ED. In our normal ED, presentations, about 23% of them were older and frail. In the new activity that we got, 80% of the presentations were older and frail. And I think without MACI having started, it really would have been impossible. But we saw what was happening and we said, well, this is a huge increase of people coming in at the front door. How are we going to deal with this? So we actually merged a number of other teams that were operating throughout the health service, that were on the ward, that were already in ED with our team. We also have a domiciliary multidisciplinary team, Marta at Home, which is medical nursing and allied health that go out into the homes or into aged care facilities to provide care. So we tried to create a pathway that incorporated all of those and bring it all together. And really what we were looking at is, could we amalgamate and redesign these resources and reduce duplication and close the care gaps that we thought existed? So that was sort of the journey that we've been on, and this is sort of where we're at. So I developed, my interest is really trying to look at the health system and looking at a governance for a health system. And the systematic review identified 10 key elements that we really need to address across the health system. This is primary, acute, social, whatever. But if you're looking at a population, what are the things that we need to do? Those, I put it into a balanced scorecard, and the reference is there for the systematic review. But these were the 10 elements that were described. I'm not going to go through those in detail here, because that's not what this is about, but we're doing a workshop tomorrow, and I'll go through more detail about the 10 elements. The two that were in yellow, or orange, are the information communication technology to share information. We don't have a shared electronic health record in Australia. Well, they're trying to have one, but we haven't got one yet. So we did have a shared resource. We had a book that went with patients, that followed patients, but we don't have that. And that was why that's in orange, because we're not quite there yet, although we did do some things to help improve information exchange between the multiple providers. And we also have a funding model which is very much, you're either in hospital and it's activity-based funding, or you're in primary care and it's fee-for-service. So our funding model does make it problematic to do this work, but that didn't stop us doing it. So who was the team? So these were for patients. Those are the eligibility criteria. As I said, it's for older persons 75 years and older, but if people were Indigenous, that was lower. I think the rest speaks for itself. I think people would probably know what the eligibility criteria are for the frail and elderly. I don't need to go through those. The team primarily was clinical nurses in ED. These aren't emergency trained nurses. These are nurses who have worked in the community, they have worked in primary care, Some of them have worked in wards in hospitals, but they come with knowledge about what the community and primary care can offer, and that is really important from two reasons. One, the ED nurses initially resisted it because they're not emergency trained, but also because their focus very much is on the whole care of the patient and the continuum of care, not just about managing an acute presentation when they present. We have a social worker, we have a pharmacist who's based in ED, an educator, and we also have some research time. So the outcome so far, that's really just to show you what our problem was. So the increase in people who are coming to ED, this is just our ED, it's increasing and it's continuing to increase. The clinical frailty score, this was the outcomes of the people who are coming to our ED. Now the important thing to note here, a bit behind, is the orange box here is those who are vulnerable and at risk. The ones here are independent, they're the ones, all the older people who are doing the normal thing well, generally don't have too many problems. These ones are the ones at risk in the orange, and this group here, this half, are that group. So you kind of go down the scales from vulnerable, mildly frail to moderately frail. And then the end ones, which are really those in aged care facilities who are palliative end of life, very, very frail. And this is this half of that population. The interesting bit for us was this 35% here, who are moderately frail. Because what we're not doing is we're not identifying those until they're coming to the ED. And we're not actually looking at how we identify them prior to that, because they're not in aged care facilities, they are generally in the community. And this is something that we're now looking at and working with our primary care organisations. We have primary health networks, which are our primary healthcare organisations, and our primary care providers, GPs and practices, to look at how we actually identify those before they actually start having problems. So the outcomes so far, as I said, 35% are classed as moderately frail, and the first time they pretty much have any problem is when we see them in emergency, which I think is a failure of the system. I think 55% of them have a cognitive impairment, and 100% of those 55 are at risk of a delirium, falls and pressure injury. They're a high-risk population. Nearly 50% had no appointed decision maker, and that's a huge problem when you're getting people in with cognitive impairment who are older and frail. The impact that has on them and on their journey is significant. They end up getting in hospital, they're stuck, and to make decisions becomes very difficult, and it's not often a very good, if it is an end of life, it's very protracted and very painful. 80% of them already receive care and 30% of them live alone. 40% of the patients who came to the emergency department were seen by the older person team. Not everybody who comes to an emergency department are old or frail and need to see them. So of the total population, and that's still a significant population for 3.4 nurses to see. The average time spent was an hour. 80% of the 40% that were seen returned home from ED in short stay unit. Previously, probably more than half of that, probably near about 2/3, would have been admitted to hospital. So that's really significant, and the idea being that these nurses and pharmacists, allied health, they actually work with the community, with the ambulance, the primary care physicians, the aged care facilities, to look at when they're first coming in. The GPs now phone saying, I'm sending them in, this is the background, this is the collateral information, as we say. They're actually telling us what the problems are, so that if we can proactively try and plan for them to go back out. And as an example, if someone's on warfarin and they've had a fall and they need to have an X-ray, we don't, but there is a mobile X-ray service, but you have to pay for that, and not everybody can do that. But if we know they can come in and they actually don't go to ED, the best is 7 minutes. We've had them come in, go straight to X-ray, have the report done and go back again. Because we know from evidence that the less time that they spend anywhere near an acute facility, if there's no other reason, it's best. Because we start testing, we find so many things wrong with them, they're admitted, and then it all cascades from there. We've had a 220% increase in referrals to our Martyr at Home, which is really our multidisciplinary team. We have physios, OT, speech therapist and a social worker, as well as an infectious disease physician. They also do hospital in the home, but these really aren't on that programme. There's been a 19% in hospital admission rates. Our representation rates of this population aren't any greater than the rest of the population that would represent. It's the same percent, because people keep saying, oh, they'll come back more. They're not coming back more, it's just the same. And redistributing what were ward-based services into this team, which goes across ward and ED, hasn't made any difference to the outcomes on the ward, but front-ending it has had a significant impact on managing these patients. So the lessons learned. So there has been an increase in total presentations of this population over the last number of years. The majority are severely or moderately frail, and they are very much at high risk of hospital-related harm should they not return home if they're able to. I'm not saying that not everyone should go home. Some of them are admitted, but for those who can go home, they should. We have been able to show that having this particular team based in ED, but really truly linked with the community. You know, we have a working group which has GPs, the ambulance, some hospital physicians and nurses. We have a consumers, what did I say, aged care facilities, I can't remember, it's about 30 people. But it's actually the whole of anyone we can think of that wants to come in, they can come in. Our primary health networks to look at how we can use our resources more efficiently. And it has an impact. We use the quadruple aim to measure. The MACI showed a 10-to-1 cost benefit. We've had an improvement in the various clinical outcomes. We've got staff satisfaction improved. It's very difficult to measure patient satisfaction because so many of them have a cognitive impairment. So we've actually basically looked at and worked with families and got their impressions of their satisfaction, because really a lot of these decisions are being made on behalf of these people by their families. Assessing frailty at the front door is amazing for patients. You know, it really puts the focus on what is it that these patients want. And I think, you know, we say it's like having a crystal ball. It's being able to assess very quickly those who are at risk of poor outcomes, who can and are safe to go home, with communication from all the other providers that they would normally have access to, is absolutely gold. It really is. I've been quite surprised, even myself, by the outcomes that we've had. Some patients will return, some patients always return. We can't stop that happening. That's kind of part of the course. But they're not returning at any greater rate than any other part of the population. The most powerful weapon that we've had in trying to do this and do this change has been data. The clinical nurse who runs this, when she first started, she was the one FTE. She said, I'm doing nursing, and I don't like data because I'm just doing what I like doing. 3 years later, she's going, I really haven't got time for nursing because I've got to do the data. Because at the end of the day, when we've had to stand up in front of the board or funders or, you know, researchers or anyone else, having the data and having narratives, I think the previous presentation and someone else this morning talked about the use of the narrative, and having narratives about what the experience has been like from the family and the carers and the person's perspective just is incredible. We presented to the board and I put up a couple of journeys and a narrative from a particular journey. And, you know, we had the 10-to-1 cost benefit, we had the improved clinical outcomes, we had all the great things. And then I showed these two, they said, well, that's very nice, but, you know, you can't have any more money. So I said, well, you know, this is the journey of two journeys that we have. And they said, oh, well, that wouldn't happen here. I said, no, that was 3 weeks ago, and that was 2 days ago. And they go, well, that's awful. So, you know, the power of the journey and the narrative cannot be underestimated. So I could just leave now and say, we've done a great job, all right? But as the title suggests, it wasn't all that easy, and it doesn't continue to be easy. For all of the good things that have happened and all of the great things, you've all seen the culture triangle, I'm sure. So it is person-centred. We did have a vision. We had collaboration and partnerships from everyone that we could possibly think of, including the consumer voice, or carers in this case. It was clinically led by multidisciplinary teams from both primary care and the hospital. We are dealing with a complex system, and we know that, so we try to be collaborative and have the partnerships that we thought we needed. It is about changing the behaviours and practices, and in many ways we have done that in some areas. Like I said, within ED, the nurses now are a fundamental part of it. primarily the ED director, who initially trained as a physio, then worked as a GP, is now an ED physician. He's fantastic. He understands the various parts of the system, and his leadership has been fantastic. But even getting the buy-in from the new registrars or the interns, the various members of nursing staff, has taken time, but we've got there. However, there's a lot that lies beneath, and I guess this is the final slide, but it's really what I wanted to say, is that all of this is about people and culture. Whilst it's primarily for me about the patient and about the outcomes for patients, but the change is about people and culture. And to try and align those with all of those things that lie beneath the triangle is something that, 4 years later, and I thought we've done a good job, I can now, as I do as a Director of Integrated Care, do something, change it, and it moves into normal practice, thinking, my job's done, I can move it. Yet there is still the rub between all these different things. So we talk about inter-organisational, interprofessional education. We do that. But it's intra-professional as well. It's between, the GP, the ED doctor, the general physician, the geriatrician. Everyone thinks that they kind of know what's best for these people. It's between the nurses in ED, the nurses on the ward, the nurses in the community. It's all about, well, we can do this here and we can do that there. And it's very easy, not easy, but it continues that unless you have this particular team, in our case, as the glue really that holds it together and focused on that continuum of care. It's the way we're trained in Australia, it's the way we're funded. We are funded to have people admitted, and the community is fee for service, they're funded to see people. So when we're saying we can stop people coming in because it's good for them, as a general physician has said to me, but I'm going to stop my funding stream. So we can prove that it works, we can prove that it's great for patients, but to get hearts and minds across the board, it really does come down to leadership. We need, in our case, the boards, the senior clinicians at all levels to really say that, no, we understand that and there's still plenty of work, but this is better for this patient group. And it takes a bit to stand up and say that when you've got some quite powerful people in the room saying it's not. It takes a degree of trust. Our aged care facilities do a great job, and yet they do get hammered a little bit about sometimes the care that they provide. They often don't have the same level of staffing that other places have, and access to a lot of other multidisciplinary parts of the team. But they have come so far with us. When we first started 5-6 years ago, nobody that were coming into the MATA had an advanced care plan. Now 88% of them do. Many of our aged care facilities have stipulated that when people go to their facility, that they have to have an advanced care plan as part of going there, which makes their care and those early conversations with their carers and family a lot easier to have. We do interdisciplinary and multidisciplinary education and training, both with primary care and the acute care system across the region. But really, we try to align KPIs and incentives that we can affect, but we cannot affect all of those, and we can't change the fact that hospitals get paid for activity. But we have tried to say, whilst that's not what we're about, but we do look at those other KPIs, we're really about the patient and about what their outcome should be. That's it. Thank you.
Yeah, so we'll just now go directly to Q&As. So we'll just like to check if Michelle from Alaska, she is online with us, so she could eventually take some of the questions. I don't see. Michelle, can you hear us? Well, eventually, while we try to solve some technical problems, I would start maybe to start collecting some questions from the audience. Okay, that's better. Okay. Does anyone have some questions for either the first one or the second presenter? Eventually, nothing yet. Hmm?
Can I ask a question of the audience?
Yes, you can.
Does anyone else have similar issues or have they experienced similar issues in trying to get change to happen across organisations? There's nods.
I think everyone has issues, but like...
And what have you done?
Can we have a mic? Here in the...
If you don't ask me, you see, I'll ask you.
He's arriving. So, I will actually ask you to introduce yourself, so...
Oh, right.
Okay.
Is that on?
It does work, yeah.
Yeah.
Yes.
I'm June Roberts from Salford in the northwest of England, and we've created an integrated care organisation where we have adult social care, acute and community services, mental health, and we're working in an alliance with our general practitioners and with our voluntary sector. And we've been particularly trying to tackle frailty, and the leadership style has to be very inclusive, have to listen very carefully and understand each other's issues. And as you said, it's a long journey. It's not something that's going to happen overnight, and you really have to work at it to keep your partnerships going and to keep your staff engagement really strong. So although we've set a direction of travel around the integrated care agenda, what we really try to do is also get the ground up ideas, because things that you've just discussed around frailty here have come from the ground up. This is what we need to do differently. And with Michelle, using a real quality improvement methodology. So we're not setting off and putting pilot schemes in, we're doing tests of change and using the same PDSA cycles so that you can really see if something's working and change direction. If not, and that's engaged the staff particularly well, I think.
Thank you.
Do we have any other questions from the audience? Looks like we don't. So actually, I wanted to ask you something from my side. You know, from your presentation, you know, you set out some, let's say, challenges or things to consider at the end. What's the first one that you would actually, you know, put there as sort of priority? You know, something also coming from the first presentation was the importance of evaluation, how this takes time. So what's like, let's say, if you have to pick one thing to let's say, to start to kick off the process?
Well, the next step, I guess, is I think a lot of this work is, as we say, you don't ask for permission, you just ask for forgiveness. As long as you've got the clinicians behind you and it's in best for the patients, we choose the bits that's going to have, I guess, the best impact with what we've got. And I made note there of the need for us, where we're at, looking at that group of patients or people who are in the community who are at risk. And really we want to look at addressing that so that those people aren't actually coming to ED. I think, you know, all those other things aside, with the intra sort of professional stuff, I think that the way that you overcome that is having the evidence and having the data to say at the end of the day, it's making a difference to people's lives. And it really, and that's what we've done with, you know, that's what we do, we do research. It does take a while for it to get published and out into the public domain, which is a problem. But really to carry on doing that, creating the evidence and including, in our case, carers, rather than the patients themselves, for all the reasons I've said. And just, you know, to show that it works. And I think there is a lot of interest in what we've done and other people are starting to do it. So it's really not to stop and wait and let the barriers take you down, but look at those people who are willing to go with you and take that and create the evidence to do it. Because otherwise, I think there's that, you just get stagnant and it, you know, they can stop you if you don't just let it keep going. But that's just me.
That's great. I see some technical communication. Okay. Only audio. Okay. So I think we now solved the technical issue with the connection. Oh, Sorry. We have another question in the meantime. Sorry.
Yes, I have a question.
Good.
But excuse, I am French and don't speak English so well.
Better than my French.
And you had something on the last picture about incentives. And I would like to know what kind of incentives you had.
So, is that the one? Oh, you haven't got it there, it's up there. So, rather than incentives as in money, because we can't change that, really we try to make the incentives about it's engaging the patients or the carers and trying to look at how we collect the data. We know that we've collected data to say, in our case, in just one site, but what the cost and how it's more efficient to do that. But in doing that, you know, you can say it's a 10-to-1 cost benefit, but the problem with that is that it's saving us money, but the cost is going somewhere else. So what we're trying to do now is to say, well, it's you know, a 10-to-1 cost benefit for this organisation, but where else does that cost then get passed on to? So, you know, we're trying to make the KPIs around, it's not about people who are being admitted, it's about more the social determinants. You know, is that where they're going home, is that where they choose to be, rather than medical people thinking they need to be in a hospital, if that's their choice to go home. And the incentives in this case would be those based on what the patient wants, not necessarily on what the funders want. So it's trying to look at it from a different way of addressing it, because we can't change the funding structure. We're trying by creating the evidence, but we can't just go and change that. Australia doesn't have that sort of blended or capitated model that we can do that yet, but we're trying to create the evidence to do that, and the way we do that is through really the patient outcomes.
Okay, so we connect with actually our speaker. We have about 5 minutes left, so
over here.
There's one question there, and then but we also connect from sorry,
Alaska.
The last question, yeah, the last question. Okay.
Hi, thanks very much for the presentation. It was really interesting. My name is PJ Hart and I'm from the Integrated Care Programme for Older Persons in Ireland. So we have a number of examples of what we call FIT teams, which is a frailty intervention therapy team within the emergency departments within the 13 sites that we have. And the emergency department intervention is very attractive for a number of reasons. The early results are very good. You introduce a service that wasn't previously there. You turn around a lot of people who might otherwise be admitted. But a couple of things that have proven to be problematic, which we're trying to get to grips with, and I'm wondering whether you have had the same experience. So without an end-to-end pathway agreed, without the community services agreeing that if people are turned around, they'll put in an immediate intervention in the home the following day or that evening, then the risk is that some of those emergency department teams can be quite disconnected and be splendid examples of good practice, but in isolation from the rest of the end-to-end pathway. So for us, it's been really critical to ensure that it isn't just one component of the pathway that performs well, but that the rest of the pathway is in place and that there's agreement in terms of a high turnaround and quick response, so that the results that appear to be very attractive to policymakers or to funders are understood in terms of the totality of the actual pathway.
Yep.
I wonder whether you've had the same experience.
So that the statistic there that said there was a 220% to our MATRA at home, that MATRA at home is a multidisciplinary, it's got doctors, nurses, allied health, it's got the whole lot in there, and they see anyone who in the community, but from our health service. They've been there since I've been at the MATRA, they've been there for like 20 odd years, and they've never been used by the emergency department. Never. Like, I'd count on this hand how many referrals they'd get, probably in 6 months. But since having had the team in there, the older person team, whose focus is that continuum of care and what the person needs and where they need it, you know, that's why it's gone up 220%. And the 70% of that increase has been from our team. The rest of it is from the rest of ED, because it's kind of more by osmosis that they're saying, well, they're referring this group of people to there. So I think the fundamental shift is because these particular group aren't ED nurses, and they look at it, as you know, in a very different way than if someone's coming in with a trauma or a broken leg or the child that swallowed something. It's not full on. It's more about that, collecting all the information, talking to the general practice, talking to the facility, and then about what their ongoing care is, not just we'll fix them and off you go. So I think it's collecting that information. If we just said they come into ED and we get them out again, that's great. But the fact that not just have we impacted on the increase of care in the community, but the impact that then has for the rest of that department, because the EDs have never referred to community providers. They just fix them and they either go in or they go out. So I think it is really important, and we work really closely with that team to show this isn't just about this one group of people, it's about what else is out there that then leads to. So I think you're very right. You have to look at it from the whole population perspective. And what we're going to, we want to look at sort of who they're actually referring in that group, because ours are all older and frail. Having said that, we've had an 18-year-old, because frailty isn't actually limited to age. So we call it the older frail person thing, but if someone comes in and they're frail, we still see them, or the team do. But yeah, to look at what the knock-on effect of that is, because I think that's a fundamental problem within the system about how we treat people. Hospitals in particular, do tend to silo people. So, and if we keep doing that, we're going to end up at the same place. So we're quite encouraged by the fact that we've got such it's like, this effect that's been affected everywhere else, but we now need to look at how we take that further. But you're very right. That wider impact is really important.
Okay, so I think we have finished our time. So thanks again, everyone, for being here. Thanks for the translator. Thanks a lot to the speakers and for the video intervention from Alaska. You can always connect after the session, and have a nice day. Thank you. It was good, like, to you too. It's a pity because I couldn't understand if you wanted to intervene or like. No.
Okay, so León, buenas tardes, good afternoon, thanks for coming to this session. The purpose of this session is to speak about a project that we have had the honor of participating. This project is a Robert Wood Johnson Foundation project that has been carried out by the Petrie Center and in the University of Berkeley and the School of Public Health in the University of Berkeley. The name of the project is quite long. It's Learning from Accountable Health Models in Spain, the converging narratives of integrated care, chronic care management, and promoting the culture of health. Okay. The project team, the principal investigators, the project leaders have been Richard Seffler, and Stephen Sortel, both from the University of California at Berkeley. And the project team, the larger project team, has been composed by Meg Kellogg, also from California, and the Spanish team. And today we have with us Núria Mas from ES Business School in Catalonia, Ana Miquel from the University Rey Juan Carlos in Madrid, and me, Roberto Nuño. I'm the director of the Deusto Business School Health in Bilbao, in the Basque Region. So, just to explain the context and objectives of the project are basically to extract relevant lessons in the context of transformation in the USA healthcare, relevant lessons coming from Spain. Previously, part of the research team has been involved in another study in Spain, trying to understand what's happening in Valencia region, where they have been piloting and implementing accountable healthcare models based on integrated health delivery organizations. So in this context, the main issues that or the main purposes that the project wants to investigate are how is the accountability of the health and of the financial results for specific populations in these regions in Spain. What are the roles of leadership and policy in this transformation? How are we promoting care coordination? What kind of payment schemes and methodologies are being used? And also how the evaluation and monitoring it has been performed in these regions in Spain. And finally, the dissemination of the key learnings of these approaches. And with all this information, the project will highlight lessons for the USA and give influential USA healthcare leaders first-hand knowledge of these lessons. The regions that the project team selected were these three: Basque Country, Catalonia, and Madrid. Probably are the most, are the richer regions in Spain, and are places where a lot of innovation around healthcare, particularly in relation with chronic disease management and population health management, is happening. Probably I'm going to go very fast with this slide. For those of you that are not familiar with the Spanish health system, the national health system in Spain is a universal health system that is free at the point of use, with the exception of co-payments for pharmaceuticals, and healthcare is financed through taxes, through the main taxation system. Solidarity is one of the key pillars of our system, and there is a transfer from rich to poor and from healthy to sick in our system. It's a single-payer system. The money, the taxation money, is collected at the central government, with two exceptions that are the Basque Country and Navarra, two regions in the north that we have our own taxation system. These regions that in Spain we call autonomous communities have the responsibility for the planning, organization and delivery of all the public health services, and also several governance functions related to the private services in the regions. So there is a territorial organization for the delivery of health and also of social care. And this way of organizing is one of the factors that, to some extent, can facilitate the integration at the territory. The private health market represents around 28% of the total health care expenditure, and is consistently basically of direct payments, double insurance. People can have double insurance in the private market, and some specific services that are not covered. The coverage is quite comprehensive, but for instance, dental care services are not included in the basket of benefits. In the public sector, the healthcare organizations work within a global budget, an annual global budget, and doctors and nurses are paid by salary. In international comparisons of performance, it's considered that the Spanish health system is quite efficient at the macro level, with good health outcomes for little expenditure in healthcare. That's around $1,700 USA dollars per capita. Also, in the project, we have an advisory committee with several USA health leaders, such as Paul Wallace, former medical director at Kaiser Permanente, later on Academy Health, Jerry Penso, this is the Chief Medical and Quality Officer of the American Medical Group Association, Parinda Khatri from Cherokee Health Systems, Jeffrey Barnett, Senior Vice President of Medical and Market Networks at Sutter Health Network, and Tojin Ajayi, co-founder and Chief Health Officer of Sidewalk Labs Care Lab. So, and this group also visited us 2 years ago to understand how the Spanish health system and the health system in these 3 decentralized regions is organized. At the end of the project, we had last year, in April also, a final conference that was hosted by the American Medical Groups Association, and another larger group of healthcare leaders in the USA. We share the main findings and the key lessons learned of this project with them. So that's the main, it's a brief introduction to the project, and now we are going to go in deep with the specific findings that we have, that we want to highlight from each region. And we have the great opportunity and the honor that we have the lead researcher, Stephen Sortel, with us. And he's going to provide us with his comments about, in the first stage, some explanation about the objectives from the USA perspective and about the methodology that we have deployed in the project. And finally, he is going to provide his overview of the key success elements that could be applicable to the USA from this experience in Spain. So that's the purpose of the roundtable. And many thanks. This is a picture from the final meeting in Washington. And it's now time, Steve, if you want to yeah, what you want to prefer. Steve is one of the most influential persons in the field of integrated care. For us, it's a honor that he's going to speak about the project.
No. I think we go directly to Nuria. So I'll just set it up a little bit. We're going to try to save some time for your questions. But as Roberto has said, the overall objective here was for us in the United States, where we're kind of struggling with how to best integrate healthcare and social services, to learn from countries in Europe. We'd had some connections with Spain and what's going on in Spain, as Roberto has said. with these 3 different regions. And so we paid 2 site visits. One was an early site visit to learn the landscape a little bit of what the potential lessons might be. And then we took that back, and with funding from the Robert Wood Johnson Foundation, United States, they have a small program internationally. We then lined up some other people that Roberto has mentioned, the photos there, to come visit. And in between, we collected a lot of data and analysis, and our colleagues here are beginning to write papers, which you're going to hear about today. And we've put it all together, and you're going to hear the result of that. You're going to be among the first to hear this. We are writing some articles for journals as well. So with that sort of as the background, I'm going to turn it over to Nuria Mas. Nuria.
Thank you. So good afternoon. I'm going to tell you a little bit about what we have found out about the region of Catalonia. And to do that, with this? Yes. So basically, I'm going to organize the presentation in 2 parts. One, it's what I think are the key elements of success of integrating healthcare systems. And for me, one of the main conclusions is that you cannot have one without the other. You need the integration. It's the result of many very important elements that if you miss one, then the result is just not the one that you are aiming at. Just to start, let me say, Roberto has explained the main characteristics of the Spanish system. I just want to add some details about the Catalan one for the ones that are not very used to this. So the Catalan health system has a difference, let's say, because we have a lot of care provided by private healthcare providers. Before the healthcare was transferred to the Catalan region, there were already a lot of private hospitals in Catalonia, and then basically when the competencies of healthcare were given to the Catalan government, they became part of the providers of the system. So about 80% of the primary care centers are public, but 20% of the beds of hospitals are public. Okay, so we have a big mix of public and private healthcare systems. And something that is also very characteristic of what we call the Catalan model is this division between public financing and provision. So you can have the financing, it's from the Catalan healthcare insurance, which is public, and then we have different types of providers that offer their services to the public financing. And another thing that I want you to have in mind is that we have 7.6, more or less, million citizens that are being covered with the Catalan healthcare system. Now, this is just to convey the idea that I think it's going to be relevant for many of our areas, that when we think about healthcare and integrating it, we need to take into account the local characteristics. So this is just to highlight how big the socioeconomic differences can be between big cities, rural areas, etc., or also the density of population. So obviously, if we are thinking about integrating healthcare, we can just not do the same thing when we think about a rural area that it's in the mountains, for example, or in a rural area that it's in the sea that receives lots of tourists, or in a big city like Barcelona. And that's the message that I wanted to convey here. Basically, in Catalonia, what happens is that every 4 years, there's a Catalan healthcare plan that determines the key directives of the strategy that the government is going to follow for the next years. And the source of our analysis is the healthcare plan from 2011 to 2015, because this plan really focused a lot on tackling chronicity. And in particular, they developed 2 types of plans. The first one is the program of prevention and attention to chronicity, and then the second one is integrating health and social care. So what I think is very unique of this Catalan experience is that they've started working on integrating health and social care in 3 dimensions. We have the typical concept of healthcare, we have emergency care, and then also social components. And out of this plan, there were basically 3 main goals. I'm interpreting, so that's my version. To obtain the best possible care for the population, being proactive. Let's just not wait for the patients to come to us. Let's go and find the ones that potentially would be the ones that would need more resources. And then also look for efficiency. Let's use the available resources that we have in the land, in the territory, in the best possible way. To do that, they have these 4 key enablers This is what I think, that's my interpretation. One, of course, it's identifying the patients that need all these resources. That's the first step. The second one is to share this information. If you don't have electronic care records, it's going to be very hard for you to integrate. This one, and I'm going to talk about that with some detail, it's the shared individual intervention plan, and the last one, the local agreements. I think that the most specific and maybe probably more different ones from what you are used to see are the last two. Okay, so let me start with some details. I just want to give you some sense. This is from some paper whose writer might be around. So I just want to highlight that there will be two groups of patients that are of a special interest for that. The complex chronic patients and the advanced chronic care patients. Complex are 3.5% and the advanced 1.5%. So we start with the stratification of the population. That's probably not so different from things that you've already seen, but there are two elements that I think are very interesting. So it's not only a matter of identifying the population, but it's also labeling them. Once I've identified the patients that are advanced chronic patients or complex chronic patients, I label them so that everybody in the system can be aware of the type of patients that they are dealing with. The second thing that I think is also very interesting is this proactive approach. The providers were told to look, the primary care in particular, to look for the patients that would fall estimatedly in the region. And actually they were very successful with that. And then another thing that I think is quite special is this. So basically the way in which you identify these patients, it's not only with an algorithm, with objective measures, that's very important, obviously. But then there's something that I think it's very interesting, which is the clinical judgment. You might have two patients that look exactly the same, and one of them lives alone, he's a widower, and his children are very far away, and another one lives with his wife, who is perfectly healthy. These two patients necessarily will need very different type of attention. And this is something that they are including. Okay, so that I think it's the labeling, the identification so that everybody can see them, the fact that it's this combination including social criteria, and then of course there are guidelines for professionals. Once the patients are labeled, you can see this label as a complex chronic patient or as an advanced chronic patient. Advanced means that maybe the remaining estimated life expectancy might not be that long. Everybody can see that. When I mean everybody, I mean every provider. Okay? When I call the hotline in the emergency room, for example, I just call, I dial 061, and they will see which type of patient I am. When the ambulance comes, they know which type of patient I am. Okay? That's something very important. Then that's the other part, the third one, the shared individual intervention plan. And this is one of the things that when I learned about this, I found more interesting. What's this shared intervention plan? It's an individualized, personalized plan. Okay, once you identify one patient that has some characteristics, you personalize the type of care that he or she needs, and it takes into account not only the medical things, the physical complexity, but also the social environment, like the example that I've been telling you about. It's not the same living alone than living with your partner, for example, and also the psychological needs. Do you feel comfortable taking care of yourself or not? Do you feel empowered? Or are you worried that you cannot control your disease? Okay? It also takes into account the patient's values and preferences. And you see what I mean with that. Okay? If you are really, really sick, maybe, you know what, probably at the end of your life or this, do you want to spend more time in the hospital or you prefer to be home? This is important. This has to be in this part of plan. And we need to have a conversation about this, not only with the patient, but also probably with the family. Okay? And this is what it's done. That's why it's elaborated collaboratively between the general practitioner, the patient, the different social care providers if they are involved, and also, I insist, the family. This is very important with this type of patients. Some of them might need the involvement of the family, some might not need that. And it's a dynamic document. This is also very relevant because the situation changes. The chronicity keeps evolving. You might change your mind. You might need something different. Your kids might come back and be closer to you, etc. Okay, so it's very important that it's dynamic and it's periodically reviewed with your primary care patient. And as I was saying, it might include advanced healthcare directives. Where do you want to be treated, in the hospital, home, etc. And of course, this is included in the shared electronic medical records. Because when everybody in the provider side sees you, they need to know what's the plan that you've negotiated, that you've discussed with your primary care doctor, together with the other elements in the system. And that's something that I think it's quite unique. This personalized plan that it's included in the records, with care instructions for everybody. Okay, so what it says is, in case of crisis, what is going to happen? In normal situations, what's going to happen? Okay, and that's what I'm emphasizing. Okay, you have instructions for stable phases and for crisis. So, for stable, what do you have? Contact phones. Who should you call if something is going on? Is it a nurse that is your contact? Is it the primary care physician? What's the WhatsApp? Whatever works for you. Okay. The revision of the medication, follow-up services, etc. The key here is to keep these patients stable for as long as possible. But of course, with this type of patients, from time to time, you have crisis. Then, what happens in crisis? Well, crisis might happen during opening hours of a primary care center or not. And obviously, the plan needs to be there. You can just feel comfortable managing your disease if you know that there's a plan for that. You know what you have to do in a crisis, you know what you have to do in stable situations. In working hours, you go to the primary care team. Non-working hours, you call 061, which is the healthcare hotline, which will again see whether you've been identified as one of these type of patients. What does this individualized plan include? As I'm showing, this is what you can see. Health problems, medication, who is the person in charge, do you live alone, live in a residence, all this social information as well. Okay, I don't want to spend too much time with this probably, because I want to tell you a little bit more things. Let me just pass, but that's what I was just telling you before. Okay, so you can see directives in case of crisis, etc. Okay, more things. Sorry, it's going very slowly. Let me advance on this, because what I want to tell you now, it's about more. I think I've been stuck in here. It doesn't seem to move. No, okay, sorry. So the third point is the shared clinical records that we've discussed. And then the fourth thing is this local agreement. Okay, this local agreement, I also think it's quite unique of the Catalan model. Basically, this takes into account these differences that I was telling you about before. Okay, because it's not the same if you have a big hospital around you than if you don't have it. It's not the same if you live in the mountain than if you live somewhere that is more accessible. The plans might be different. You might have a region that has a mental care facility or a region that doesn't have it. So obviously, the response will need to be necessarily different. And this has a local focus, and what it does is to develop a care pathway locally. If you have this type of COPD, for example, or diabetes, what's the local focus? What's the local response that we are going to have here? And it's written, and it's a formal agreement. The local providers, the local leaders get together with the objective of getting the best possible health for this type of patients, and they decide how they are going to organize themselves to respond to that. And I think this is kind of very empowering and quite unique. And it establishes the criteria and methods for interprofessional communications. Of course, it has to guarantee a continuum of care 24/7. So you have a local response in working hours, a local response in emergencies, and also very interesting, there are evaluation criteria. Are we doing a good job or not? And that's signed. How is this done? Well, you identify the pathways to organize all the people involved in healthcare, and it gives them the flexibility to adapt to the different characteristics of the territory. And how is it elaborated? I'm just summarizing very quickly, but as you can imagine, it's a lot of work. There's first a group of experts in the national level that said which are the key objectives. Then there's a second group of experts at the local level that basically borrow from that and elaborate their response. And basically, it's transmitted their local response to the Council for their approval. Basically just to show what's going on. So let me show you, out of these 4 enablers, which are the results that we have found on this. This is quite technical paper. What we've done here is to use a synthetic method. What's this synthetic method for the ones that are not used to this? So most of the times, when we have a treatment group, you have to find a control group that is quite similar. And sometimes when you talk about regions, people might not agree. You might say, I know, close to this region, there's another one. That's not the right control. And that generates controversy. What this synthetic method does is to say, look, which are the key elements for you to decide which is the right comparable? Is it the population? Is it the income? Is it the age? Is it the complexity? Tell me what matters. And then, with all this data, the expenditure, all the socioeconomic indicators, the complexity of the hospital, do you have a big hospital nearby or not, population and so on, we create a synthetic comparable. It's invented. It doesn't really exist. It comes from giving different weights to different things. So that I like very much because it's transparent. If you tell me, no, what matters is the color of their eyes, okay, I can put it here. Probably I won't have this data. But you see what I mean, right? So this comparable is elaborated based on the things that you believe that really matter to do the comparison. And then we determine which are the treatment groups and the control groups. Why? Because there was this Catalan healthcare plan that I've been telling you about, but as always in life, some regions really took to it and they adopted it very quickly and they did an amazing job at integrated, and some just lagged behind, okay? And we have different methods to identify which are the real applicants of this thing and the ones that didn't do much, okay? And basically, this is what we see, okay? So this is the treatment. Here, this drop, actually, it's because we just have annual data, so it looks like a drop, but actually I should see points. The drop is here. So what's this thing? This is the avoidable hospitalizations. These hospitalizations that should never happen if the integrated care was working as it's supposed to be, and if primary care was doing all the jobs, etc., right? And these avoidable hospitalizations have been ranked and identified in many papers, so we follow the same identification. The interesting thing here is to see that the synthetic, which is the dashed line, it's the same. The synthetic is created to be very, very similar to the comparable. And then what happens when they start integrating? Big drop. Okay, now we have to be sure that this is something that makes sense. So I just wanted to show you how this is done without entering into many complexities. But the idea would be that what we should see here, if instead of picking the treated one, I pick any other area, the differences should not be that big. So the point is that the difference of the synthetic and my area should be 0 before the treatment, right? Before something happens. They are the same. That's how I create this synthetic. And then after that, I observe a big drop in avoidable hospitalizations, right? They are many, I have less avoidable hospitalizations. This is the one. In the other areas, this doesn't happen. Okay, so that's a good way of checking that something is really going on in this sector that was so good at integrating. And the same thing can happen if you look at the readmission rate. Now here the synthetic is not that good. I must tell you that part of the problem here comes because we would like to have individual data, but unfortunately we could not get it. So we only have data at the very small health area, but it's still not individual, so it's risk adjusted and so on, but I would have preferred to have the other type of data. Just to conclude then, my main takeaways from this is that when you try to do integration, as I said at the beginning, you have to tackle many pieces at the same time. It's a result of many things. And you can just not touch one. You have to decide that you are going to integrate and then just go for it with all the pieces that are necessary. For me, the pieces that were very important are the ones that I already mentioned. The local part is very crucial, I think. It empowers the local providers and it recognizes that one size doesn't fit all. And finally, we have very good results of the countries, of the areas that did integrate. So now I pass it to Anna, who will tell us about Madrid.
Okay. Thank you, Nuria. For me, it's a pleasure to be here. While they are putting my presentation, I'm going to start talking about a few differences that we can find in Madrid region. One of the differences is that we have a single payer, like the rest of Spain, but the single payer that is the Madrid Health Service is also the main provider. And this is one of the characteristics. With some hospitals, a few hospitals that are public hospitals with private companies managing them. And the other characteristic is that respect of the rest of communities in Madrid, where they are divided in areas, we have a single area, and we have free choice of family physician, nurse in the primary care, and hospital specialty. So in this context, to share information, it was more needed, even more needed. After the first visit of our American colleagues, and after exploring all the initiatives, after analyzing all these initiatives and prioritizing the main initiatives, the three initiatives that were selected to share with the rest of the American colleagues were these three options. The implementation of the strategy of care for chronic conditions, the palliative care organizations, and the two case studies that we have made about analyzing the implementation process in a concrete territory and analyzing the impact in that territory. Respect the strategy for attention of patients with chronic conditions. For us and for many of the communities, autonomous communities in Spain, this strategy of chronicity has been really the strategy that has impulsed the development of integrated care initiatives in many regions from our point of view. And it has put on the floor a lot of initiatives and projects, but I have selected those that, from my point of view, are nowadays a reality that is changing the different regions. First of all was stratification. We use the Catalan system, GMAs, and we use it for planning and also for decision making for the clinicians. This is about the stratification of the Madrid population, with about 55% of population with relevant chronic conditions. And this element is in the electronic health record for the decision making of the physicians and nurses. And the second step was to try to adapt what we call level of intervention, to try to adapt the individual plan to the needs of the patients, establishing each patient in a concrete level. So we have to adapt all the protocols in our region that were the main portfolio for the primary care services. So we adapted to these three different levels of intervention. It's very similar to the Kaiser Permanente model. We adapted it to the different intervention for hypertension, hypercholesterolemia, chronic heart failure, COPD, all the diseases, and also for the detection of fragility and problems in elderly people, for dementia, and for the palliative care. So we have all these protocols adapted to the different levels. And they were also taken to the electronic health record as registers to try to support the decision making for physicians and for nursing. The second element, the third step, was to develop a concrete pathway for patients with complex needs. This pathway was shared between primary care and hospitalizations, and also by a relevant part of the social workers, and included the detection of these patients, the proactive follow-up of this patient, the detection of the compensations, and also the continuous communication between the multi-professional team that was acting around the patients. And added to this element, for example, we have some data. These are data from the last February. About 1,391,000 patients have been included in a specific individual plan, in a specific level of intervention with protocols adapted to the needs. And about 18,000 patients are included in the pathway for patients with complex needs. So some things are changing. Added to this, there are another initiatives, for example, to try to promote an empowerment and self-care of patients, including the creation of a school of patients and caregivers. And another key element of this movement of transformation with the chronic strategy was the impulse of the shared electronic health record. For us in Madrid, as we have free choice, it was a very relevant need. Probably it is not in the position that every professional would like to have. But for example, I am not only a professor in the university, I work as a family physician every day. And one of the things that have changed my life is that nowadays I have access to the main information of my patients. So I can have access to the hospital reports, to the order analytics, if they have gone to the emergency room, everything. So now also the things are also changing. The second project that we selected, that for me it's really paradigmatic of integrated care, was the palliative care organization in Madrid region. With two plans, palliative care, end-of-life plans, the last one from 2010 till 2014, a net of resources to support the end-of-life patients was established in Madrid region, ensuring the assistance 7 days a week, 24 hours a day. And with some key elements, for example, the home support primary care team that support the primary care physicians and nurses, but also give direct assistance in many cases, and it's a relevant element. Another element relevant were some mid-state unit that, in case that the patient didn't want it to die at home, was able to go to these specialized units. And a very special thing is what we call PAL 24, that is the way in which we have ensured this continuity of care with all the elements, with a phone call center that it's acting 7 days a week, 24 hours a day. And finally, a key element is the shared electronic health record that it is called InfoPal, that it is shared by all the actors, all the professionals that can act anywhere. And some of the data of this palliative care organization is, for example, these are public numbers. In 2017, about 9,000 adult patients with palliative needs were attended, and from this, about 7,500 were attended at home by the specific teams. So many of them die at home. This is a key element. And finally, we would like to share with you 2 case studies that we developed in a concrete territory in Madrid. We selected the territory of influence of one hospital, and we tried to evaluate all the implementation process and to assess the impact in that territory. Why? Because it is a territory with a difficult situation. It is attended by a hospital, a private hospital, managed by a private public hospital, but with a private company by a concession of 30 years, with their own specific managing team, with the primary care health centers with 21 offices, different offices, suburban and rural offices, that are managed by a specific public team and depend of Madrid Health Service, and the 45 nursing homes of different origins, public, private, and they are managed by different companies. But it was a territory that we consider quite advanced in the implementation of these implemented care initiatives. So they have, even before the creation of the hospital, they have implemented about 28 integrated care initiatives, including, for example, new roles that try to give support to the primary care or nurses or physicians, or to try to ensure the transitional care. For example, new services, including this planning of discharge, this proactive follow-up after discharge, or, for example, the nursing home hospitalizations, for example. Or some new tools like the shared electronic health record, or what they call e-consult, that allows the non-presential, non-face-to-face communication between different professionals. And also some experiences of telemedicine. And with this, one of the main results that we found were that the use of the different tools were very elevated and increased with the different years. For example, all the elements of transitional care also were increasing year to year, including, for example, that about at 100% of the discharge was sent into the primary care, the specific report, but you know that many of these patients were followed up in 24 hours with a telephone call. And when we ask professionals for those territories through a specific survey about the perception of participation, consensus, and acceptance, for example, we identified those factors that have favored the implementation, or those that has been barriers to this implementation. And for example, the degree of acceptance of the health professionals of those new roles and services and tools receive high scores. Also, the usefulness, the perceptions of usefulness of these tools. So it was perceived as good by the professionals. And in this concrete territory, we also try to analyze the impact, for example. And we studied a map of indicators with 32 indicators, and we obtained these indicators for the total population, for the complex patients, and for institutionalized patients, trying to establish statistical analysis. And we, for example, we detected that there were improvements in the levels of control of different diseases, also in the average stay of the hospital compared with the rest of Madrid region, and, for example, in the activity of the primary care. In the case of readmission, the numbers didn't change in the readmission in 30 days, probably because the elements that have to be implemented for patients with complex needs or institutionalized were implemented in the last year, so probably with no time for change. But for example, in the case of readmissions, due to diabetes, the results were better than in the rest of Madrid region. Also, there were good results and experience of care, for example, in the satisfaction with the coordinated care that was received for the patients, the coordinated care between the family physicians and the different hospital physicians. And with this quadruple dimension of the quadruple aim, the professional satisfaction was very high. So the results were quite good in this region, and the perception of the implementation process also. But now, from all these plans that I have introduced to you and I have shared with you, I would like to share my some of my learnings during this process. For example, what I consider the key elements that are present in the different projects that have better results. And some of these key elements, first of all, is we have to have a strategic framework of an integrated care, I think, and to persist in this vision of integrated care, it's relevant. To have too many plans, too many projects, sometimes confuse. And I think even with changes in the political level or in the managers, to persist with this integrated care vision is relevant. The second one is that the difference sometimes are not, the framework is the same, the projects are the same, but we find difference in the different territories, probably because one of the elements is the managers, leaders, and the management change that is different in these different territories. And we think we have to focus on this. Also, it's very interesting to work in the cultural transformation. From my vision now as a family physician, all the organizations have a culture, those routines, those behaviors, those knowledges, real or not, that are part of the organization. And sometimes it's very difficult to change this. But it is relevant when you share the story you want to achieve, the implementation care history. And when you share it, the motivation to change is increased. Then we have some tools that can help. For example, the new pathways, I think it's a useful tool. And also some IT tools can give supports, and it is relevant to try to give useful tools and useful to help in the change. With tools that allow the continuous communication, because communication is another key element from my point of view. And finally, I think probably in many of the regions of Madrid we could find integrated care initiatives, and in many of the regions everywhere, I think. But we have to try to make the effort to try to evaluate the impact, to assess the impact. And we have to work in the implementation process. We don't have to invent many things the same, many times the same. We don't only have to decide what we want to implement, also how we want to implement it. And there are standardized methods that can help us. That's all. Thank you.
Good job.
Thank you, Anna. We are going to finish this overview of the lessons from the different regions with the experience of the Basque Country. I'm going to focus more on the process of transformation, because in this same conference there has been a lot of presentations about the evaluation of the outcomes of the integrated care strategy in the Basque Country. So I'm going to focus more on the process than in the outcomes. For us, in our analysis of what has been happening in the Basque Country in the last 10 years, we identify integrated care as a large-scale transformation strategy in the Basque health system. And it started in 2010, or around 2010, in a very difficult context. We have a population with a high prevalence of chronic disease and multimorbidity. Also, it's a population, it's a very aged population. It's 25% of the population of the Basque Country is above 65 years old. Also, in 2010, we are in the deepest moment of the economic and financial crisis here in Spain. So we are facing austerity policies, and there are a lot of budget constraints and cutbacks in the budgets. Also, there was a time of fierce political opposition and the resistance of trade unions to change. And even in the top leadership of the Basque Public Service, part of the policymakers and managers are not on board for a big transformation or for a whole system transformation. And in relationship to other stakeholders, such as the population and patient association, there is not a clear position or a clear support for a transformation around better care for chronic disease. And also there is a lack of engaged clinical leaders. Even though there was a strong leadership at that moment, and there was the political will to design and to implement the strategy for change. It was called the strategy for tackling the challenge of chronic disease in the Basque Country. And this strategy provided a vision and a shared narrative of change. The narrative of change was based on health system transformation, based on the development and implementation of an integrated care model, with the main purpose to improve care for patients with chronic conditions and by this way to contribute to the sustainability of the health system. And the strategy was based on several key frameworks, international best practice, and the available evidence at that moment about the integrated care. For instance, we used Stephen Sortel's lessons on integrated delivery systems, the chronic care model by Ed Wagner, the Kaiser Permanente Stratification methodology, the triple aim, Don Berwick's triple aim, and we, like in the cocktail, we mix these ingredients, these references, and we incorporate them in the strategy. Also, in the strategy, there were 14 projects, and there was a mix of top-down projects, mostly corporate projects for the whole Basque Health Service. The Basque Health Service is OSAKIDETZA, and also I think the most innovative part of the strategy is to try to foster bottom-up innovation coming from frontline professionals, particularly from clinicians, as a way to incorporate them, to engage them with this change process. And in the period between 2010 and 2015, around 150 innovation projects were launched, and also facilitated, monitored their progress, and their results were evaluated. In the top-down interventions, I'm going to tell later what kind of interventions, but most of them, as I have already said, are focused on the technological side. Another, I think, relevant lesson, and I think is in the literature of implementation research, is another key topic, is the role of change facilitators. At that time, 3 organizations that are part of the public health system in the Basque Country play a big role in facilitating and promoting these changes, and particularly to sustain the efforts of the clinical leaders that are trying to innovate in their everyday practice. And as you already know, it's not easy. The Basque Institute for Health Innovation participated in the design of the strategy and the development of the evaluation models and even the tools to evaluate the progress and outcomes, and promoted and supported bottom-up innovation projects. Also, a new research center was launched at that time dedicated to health service research on chronic disease, but also with a particular focus not in the clinical side of chronic disease, but on chronic care management, population health management. And they play a big role in the dissemination of those models that are showing promising results. And also within the Basque Health Service, in OSAKIDETZA, the chronic care office monitor and support the advance of the 14 strategic projects. So they play, I think, a big role in accelerating change and the dissemination of the vision of the strategy, and particularly that's a big issue in a public system like the Spanish health system, is to allow to bypass bureaucracy and internal resistance. In the research, we identified 2 waves of integration. The first wave, in the 3 initial years of the strategy, was focused on those clinical integration projects in the core of the rainbow model, this clinical integration, particularly focused on complex chronic patients and in patients with the main chronic disease in the Basque Country, that are cardiovascular disease, diabetes, COPD, and those kind of disease. And the second wave, the focus was on organizational integration, and as the result of this second wave, in 2016, all the Basque Health Service was organized in integrated health organizations. But I think it's very interesting to highlight that both waves of integration were aligned. The first wave helped the development of the second wave. Okay, to sum up some of the main achievements, I think we can say now, 8 years or 9 years later, that a new integrated care model is emerging in the Basque Country, and I think this is a result of learnings from these bottom-up integration initiatives, local innovation projects, and also the benefits of the structural integration of the organization in integrated healthcare organization that have the economic and the health responsibility for a defined population and for a defined territory. Also, a new care model that is organized also with a population-based system, but is the role here, the role of the internal medicine physicians is key, and this new model is focused on those complex chronic patients, those with the highest need. And also the combination of this model with new advanced practice nurses as case managers or liaison nurses are working quite well, particularly with this profile of multimorbid patients. Also, 100% of the population of the Basque Country is risk stratified with a predictive model that establish which is going to be, try to predict which is going to be the expenditure for each citizen in the next year, and using expenditure as a proxy of health needs and healthcare utilization. And this information is included in the electronic health record and is available for all healthcare staff. More relevant achievements, I think there has been quite a big advance and progress in prevention and health education programs, such as Osasun Eskola, that is the school of health, the programs that are try to promote physical activity and healthy habits, as prescribed a healthy life, Chipi Chapa. Also, there have been results at the cultural level. We have measured regularly the collaboration between clinicians from different care levels, and it has improved in the last years. There was a clear progress on integrated care for chronic conditions using a scale that we develop and adapt to the context of the Basque Country, but it's based on scales based on the chronic care model. And also the field of IT is, we have a lot of innovations, such as an integrated electronic health record, personal health folder, e-prescription, many telecare and telehealth innovation projects, and most of them are working quite well. Just, I'm going to finish with some of the, from our point of view, some of the success factors for this large-scale transformation in the Basque Country. We consider that the political support, the clinicians buy-in, the availability of startup funding, although we try to organize such organizational innovations, but you need some kind of funding to start. Also the role, as I have already said, of the facilitators, and also several issues that are in many papers or studies on large-scale transformations that you need time to make changes and to generate enough evidence to know if you are going in the right way. The communication is a key issue, and particularly if the context is not very favorable. Communication is the best way to anticipate or try to avoid the aversion to change, to manage the transfer of responsibilities, because there is to a large extent we are moving care from hospitals to the community and from hospitals to primary care. You need to promote this vision of teamwork, of integration between primary care and the hospital, and you need to monitor in a regular way the progress. Also, you need to evaluate the outcomes of these changes. And just this is the last slide. Another success factors, maybe not so generalizable as the other ones, probably are more context specific for the situation of the Basque Country, but I think they are relevant to highlight. In our situation, we consider that we need to organize a very powerful change team, and sometimes even this change team has to act as a parallel government to avoid the bureaucratic slowdown. Also, the managerial continuity in the healthcare provider organization, we think that it has had a very important role, because this allows to maintain and sustain the changes. The leadership, the shared vision, and the narrative of change are things very, very strong, and particularly to try to bring a vision that people can engage with it, because at that time the prevailing narrative was of austerity, and that's nothing that one is going to be very satisfied with the austerity messages. And finally, and I think this is very relevant for the USA context, basically here in the Basque Country, the change has been a cultural move, and the financial incentives and the payment incentives hasn't played a role in stimulating change, or at least a very limited role in these changes. And thank you very much. We continue now with the question and answers. Thank you.
Okay, so now we are going to go to the Q&A, and I would say even more important than your questions, which we want to have, it's also your thoughts. What do you think about what we have been talking? What's your point of view of, these enablers that we've been detecting? So any comment or question would be very welcome before Steve concludes at the end with the wrap-up of your questions and views and our presentation.
In Spanish or English? Also in Spanish and English, okay? Because we know that some people prefer to ask in Spanish, so we can do it, okay?
My name is Jay Shaw. I'm a researcher from University of Toronto. Thank you so much for this overview. Really interesting to hear sort of 3 different cases of change and the many levels and kind of approaches required to make whole system transformation. So very interesting to hear about. My question is for Nuria. I'll hold my own comments. I'm still percolating, thinking. But my question is for Nuria. One of the things I'm most interested in about this is changes in governance or governance innovation required to support these collaborations. And you talked about this really interesting process in Catalonia, where there was a national group of experts and then a Catalonian group of experts, and decisions about which metrics would be used to govern collaborations between organizations were determined through discussion between these groups. Did I understand that right? Can you say a bit more about that? And then if you have other comments more generally about governance of collaborations, how did leaders at these organizations come together and establish these kind of formal agreements?
So I will also, if somebody wants to add any comment, and I'm not looking at anybody in particular who is an expert also from the region, he please feel free to jump in. So you just tackled a very important issue, I think, because every time we talk about these different types of collaborations, the rules of the game are very important. One of the things that, for example, I have not mentioned, because in the Catalan case didn't happen, is this idea of the money follows the patient. So in Catalonia, if the social services help the healthcare system, let's say, and together they could find a more efficient way, the money that you could save from healthcare was not sent back to the social services. Okay, this is something that it is still, if you ask me, work in progress. So now, what happens at the national level, the Spanish level? Really, the rules are very basic. There are just some general things that the healthcare system should provide. So the more important thing would be the outcomes. How do you measure healthcare? And at the national level, the directives are extremely general. So I would just say, look, this is what we want. You want some, not too many inequalities, healthy patients, but the rules are very, very general. Now, when you go to the Catalan system, that's where I think the governance is very important, and that's something, and that's my opinion, one should work more on. Because something that would make the difference is how do you measure these outcomes. And that's why I said that in the agreement, there's this evaluation process. You have to say, look, I commit to take care of my mental care patients in this particular way. And then you have to show that things not only not get worse, but they also get better. Okay? So basically, this is not what ended up exactly happening. What happened more was a governance of the process. So you as a region, you tell them how you would monitor these patients, what's the plan, who would be providing care when, and then if the process, if the commitment seems okay, that's what they accepted. So mostly was governance of the process, but I think it should have been more on outcomes, even though there was an evaluation of outcomes at the end. I don't know if there should be something else to add. But it's very, very important that the rules of the game are very clear. He's my Catalan expert in the room.
Okay,
Thank you, Nuria. You have explained it very well, better than us, I think. All the process and all the strategy we have with this kind of intervention plan, the identification of the patients, and which way we are working in this kind of 24/7 scheme. I think it's very interesting. The interesting thing in Catalonia in terms of governance is we have not put the focus on structural things, but also an instrumental approach. For example, to establish some kind of joint commissioning, to establish some kind of common goals between primary health care and hospital care. For example, avoidable hospital admissions, it is one of the indicators between primary health care and hospital care to achieve together. If you have the same indicator, if you have the same goal, maybe you are driving the different kind of providers to work together. In other terms, for example, we are fighting to have any kind of exchange of information not only at the national health record, but also to establish some kind of connections between health and social care data. It takes a lot of time, it's a long journey, but we should fight to have this kind of exchange in terms of consent of the person and new regulations to facilitate this kind of thing. I think maybe in our case it's a combination of governance issues and instrumental things, and in the case of the government it's important to involve all the authorities who is responsible to take care of this population. So in our case we have the Department of Health, the Department of Welfare and the local governments, and it is very important to involve all the authorities in this kind of process. But I think it's a combination and a synergic combination of different kind of things to work in this direction.
Sorry, just to add to your comment. So it's not that every case that was proposed was accepted. So some people propose a path that was sent back to them and say, think about it twice, or again at least. Okay, but it's still, the rules are more on the process. So I think it's something that will take some time.
Yeah.
Thank you very much for this very nice presentation. I'm coming from Belgium, and in Belgium we are involved also in a project that looks at how to integrate care, starting from the issue of what we call local regional governance. But as you know, Belgium, as you may know, Belgium is much less structured as your systems in Spain. What I found very interesting is the 4 sort of key enablers that you presented in Catalonia that appear to be possible in systems that are not national health systems. So our systems is insurance-based systems with private providers, where primary care do not have any reasons to work with hospitals, and where primary care providers do not have any reason to work with social care. So all of these providers are independent providers. Maybe to Mr. Schultz, do you have experiences on how this type of key enablers can get implemented in countries that are not national health systems in such a way that they do not have, for instance, hospitals and primary care do not share the same budget, primary care and hospital do not share the same quality management procedures, they do not share the same care pathway, and so on.
Right. You want to start out?
I think that one thing, I mean, again, we are a National Healthcare Service, but for me, one key element would be maybe capitation. So if you pay for capitation for one patient, and then you say, okay, you do your best, this is how much I'm going to pay, and you decide yourself how you want to split it. That is one of the things, Catalonia is not doing that. We started with capitation and then we gave it up. I still don't know why. It's one of these things. But I think that capitation could be one reason, because basically if you have to find something that would bring the same incentives together. So you say, I'm paying you per patient and my outcome is healthy or as healthy as possible population. And then if you trust them, let's say, with the right governance structures, you let them be. Because part of the beauty of this thing is that at the end, imagine how many resources it would require from a centralized government to decide locally what would be best. For me, that what makes a lot of sense with Catalonia is that they recognize that locally if you trust your providers, trusting meaning I'm asking for these outcomes, that's what I want to monitor, and that's how much I'm going to pay for it, then you are the experts in this area. And of course I will monitor, so if you don't deliver, I will ask for explanations and I will check. But then you organize yourself in the best possible way. And I think that's part of the beauty of, capitated would be maybe one of the ways, but Steve...
Yeah, just building on what Nuria has said, it's more challenging, no question about it, but capitation payment and going towards global budgets. So I'll just share a little bit of the experience in California as an example. And so in California, we have over time, influenced by Kaiser Permanente, but a lot of other developments as well, we have increasingly about 300 or so medical groups, and increasingly they are now under capitated kinds of payments. And we have some very interesting data from just maybe 6 months ago that show that patients in California who are getting their care from what we call still pretty much total fee-for-service versus what we call partial capitation, which is like for ambulatory and primary care, but not for hospital care, versus what we call full risk capitation, which is for the whole thing, inpatient hospital as well as primary care. As you go across, the quality of care based on about 15 different metrics, we can talk about if you're interested, goes up, and the cost per member, the total spending, total cost of care per patient per year goes down. It's some pretty powerful evidence. And so we're building on those kinds of models in California. We're not the only state. We're now working, we have a new governor, and the action in the states is at the state level more. In your countries, it'd be more of the provinces or the municipalities or whatever. And we're working with our new governor to try to expand that integrated care model so that when we go to universal coverage for people in California, we're going to be able, we hope, to sustain that over time because of the way in which we deliver care. So as Nuria has said, that creates a spending target up here. There's every incentive for those doctors and whatever hospitals they're working with to keep that population well. And oh, by the way, they can't stint on care or deny care because they have to first meet the quality metrics. Before they get any of the shared savings, they have to meet quality metrics as well. So this is some of the developments. I don't know how much would be, applicable in Belgium. You have to contextualize it, obviously, but there could be some learnings there.
Go ahead, I'm reading the app, sorry, go ahead.
Okay, perfect. My name is Yulia Sherbina, and I'm from Accreditation Canada and Health Assessment Europe. So thank you for sharing your experience with integration of care. It's very relevant to other European countries as well. I'm thinking about Italy, for example, or other Southern European countries, for example. My first question is on the digitalization of health records. So you have all shared your regional experiences, but how is that then implemented at the national level? Have you reached already the states where those systems already communicate between each other, and if you faced any challenges? And a second question is also related to, you have mentioned some rural communities, local communities. So have you been reinforcing and implementing the use of telemedicine in certain rural areas? And if so, what are the major challenges that you have encountered that so far?
Well, I will answer because, I also come from the health system. So, first of all, is that we have as you say, in our country we have a common portfolio of services, but the designing of the delivery services and the management is in the autonomous communities. This is one difference. So the decision of the kind of electronic health record is decided in each region, in each autonomous community. In some communities, there is a common electronic health record between hospitals and primary care. In another, there is a shared electronic health record. So primary care has their own electronic health record, each hospital has their own electronic health record, and there is a shared electronic health record. For example, this is the case of Catalonia or even the case of Madrid. And this shared electronic health record, it is really a platform of integration with a visor that allows to share all the relevant information. about the situation of connection of the different countries, of the different regions, of the different autonomous communities. Nowadays, there is a project, I am not from the Minister of Health, but there is a project to try to share key elements of the different autonomous communities, but it is a project. The only project that it is nowadays working, and it is common, it is the electronic prescription. So now there is an electronic prescription with all the active prescriptions of each patient that is shared, but all the pharmacists and all the systems in Spain. And for example, with a prescription that I give to one of my patients in Madrid, I can go to any place here and to have access to the medicine. This is the current situation. Okay. And about the telemedicine, just a view. Probably the situation of the telemedicine, well, telemedicine is a huge quantity of elements. It is not only to telemonitor. So now there are several experiments, I think so. For example, in this region, there were an example of telemedicine connecting different professionals. But I think it is not extended as a usual practice. It is particular in some places or wheres, okay?
Just to add in the first part of the question, I'm more simplistic than that. I understand that there are many problems with people sharing, but at the end, the data belongs to the patient. So once we understand this, I think that once we have the patient data folder, whatever name we give, that will be solved. I know that there are many silos, but for me, really, it should not be that complicated because the data does not belong to the Catalan government, nor does it belong to it belongs to the patient.
For example,
and
now,
if the patient can take the data with her.
In many regions, they have access to the electronic health record. Patients have access. So I can go to another part and give access to another professional. And this is an option too.
In telemedicine, if you are interested, there's one region in Spain that I think I could tell you about the Catalan.
Galicia.
So, of course, you incorporate telemedicine, especially for rural areas, but there's Galicia. Galicia, it's in the northwest. They have a very old, they have quite an old population living in small towns. I'm talking about towns that can have 20 people. So really small, okay? And their telemedicine has made a huge difference, and there are many nice experiences that you might want to be to check. Now let me give the word to Steve to conclude about what the US
I'm going to do 20 minutes and 5 minutes. No, really. I'm just going to hit 2 or 3 points, I think, stimulated a little bit by your questions, but more by the presentations as well. Some of the lessons we take from the experience we've had working with our Spanish colleagues over the last couple of years. The first one is begin with your population. Begin with your patients. What are the needs in your country? What do you know about them? In most countries, about 5% of the population will account for the majority of your healthcare spending. Maybe 50–60% of it will be that 5% of the population. And they are those of your fellow countrymen and women who have multiple chronic illness. And more importantly, if you have multiple chronic illness, one of them will be depression or some mental health. So you have to substratify by that. And then further, often it's the frail elderly. And we've had sessions here today, right, about dementia and Alzheimer's and so on. So it's the multi-chronic illness, it's the mental health, it's the frail elderly that you need to really stratify. And those are the ones that are going to, in particular, need well-coordinated, integrated care in the home and wherever, right, their care takes them. So that's the first point. You know, a corollary of that, which you may not agree with, resources are always constrained. You have to set priorities. So integrated care maybe isn't for everyone in your population, or is not needed, or where are you going to make your investments. So you want to be very prudent about where you're going to make the investments in having better integrated care. Second point is the personal health record, which again, some of our systems in the United States, they have them within their own, medical group or, hospital medical group system, but they can't talk to each other outside of that. Or the electronic health record that's in our physician offices doesn't quite match with the one in the hospital when those doctors hospitalize their patients. We're working on that. Progress is being made. So it's the interoperability of the medical record that's so important. And in Spain, they seem to have that. We have something called HIPAA, patient privacy. It's very important. It was developed a number of years ago, but perhaps we need some upgrading of that in order to allow for the greater sharing that needs to occur. So I think that's a second takeaway lesson. The third, really, some of the work in San Sebastian and elsewhere throughout Spain is around how do you get the integration of the health and social services, right? If you don't do it with the budget up front, can you do it after the fact through pooling or braiding or at the point of service, right? So people aren't fighting social services, housing, and so fighting with the healthcare system over, who gets that money and so forth. So this is an issue. And so one of the lessons we've learned from Spain that we're incorporating into the US to some extent is accountable communities for health. That's what we call them, accountable communities for health. And what they are is they're a interdisciplinary group of organizations in a community in which there's something we call a backbone organization, a central organization that's accountable for bringing together the local hospital and health system, the housing department, the transportation department, the school system, okay, community development agencies, the health department, of course, right? And they then look at the social service needs of this population. And one of their biggest challenges is, of course, building mutual respect and trust. They're working on that. But it's the data, again, it's the data exchange. And so one example, if you're interested in following up, is in San Diego, California. The county down there is relatively far advanced in this idea of the accountable community for health. And they have a 211 system in which anyone in the community presses that, and there's all kinds of resources that talk to each other, whatever that patient needs. I'm the primary care doctor. I can't keep in my head, my electronic health record doesn't work, 211, and they'll connect my patient. And I get the data back so I can follow them the next time. So those would be three lessons. We don't have enough time for more, but it's really the importance of stratification, of data and information exchange and visibility, and then recognizing that health depends much more on some of the things that Michael Marmot was talking about today than it does on the medical care system. We all recognize that. When you need medical care, you need it, you want it to be good, you want it to be coordinated, but we need to have those boundaries more permeable between our healthcare system and our social services system. So I think, Roberto, that would be my very quick summary.
Thank you.
Okay, thank you.
Okay.
Yeah.